Ladies and gentlemen, I'm Joseph Atick, Executive Chairman of ID for Africa, and it's my pleasure to welcome you to LiveCast number 47. In this episode, we delve into a groundbreaking topic that has the potential to become an important element of the digital identity agenda in the not-so-distant future. This topic is about the intersection of two revolutions in digitalization, healthcare modernization and digital identity. The inherent synergy between these two domains suggests an inevitable progression where health emerges as one of the most significant use cases and demand drivers of digital identity. This evolution will give rise to a host of issues that merit meaningful examination by our community. Today, we will only have time to launch this important exploration, but even so, we will cover some significant grounds. Our episode is organized into 5 segments as follows. In the first segment, 3 African health officials will provide insights into the challenges and aspirations of digitalizing health. Segment 2 will feature a policy panel on health IDs, their types, and associated advantages and risks. Segment 3 will consist of 2 spotlight presentations on patient identification, offering a comprehensive view and updating progress from Ethiopia and other African countries. In segment 4, we will hear about the UK's National Health Scheme's identification platform, followed by a presentation on the role of biometric-based identification in enhancing last-mile health services delivery in Africa. Lastly, segment 5 will explore the potential synergy between health and civil registration, focusing on leveraging health facilities to boost health and death registrations. So why is health a topic of a major LiveCast today? The last thorough exploration of this subject occurred during 2018 AGM, when we had a workshop called DigiHealth. It became evident at that time that the topic was not mature. Today, we are reassessing health as a critical identity use case, but your feedback is essential. Please share with us whether you think the time has come to give digital health more prominence within the movement's knowledge platforms. For us, it's not a matter of if, but when. We firmly believe that digital identity serves as a cornerstone for the modernization of healthcare systems. It lays the groundwork for enhanced interoperability, efficiency, security, and patient-centric care, facilitating seamless continuity of care while tackling the multitude of challenges prevalent in the health sector. But what type of digital identity does the healthcare sector need? As we shall see today, within healthcare, identification serves more as an administrative tool for fixing identity for continuity of care, for example, rather than for establishing a unique legal identity. The challenge of identification offers opportunities here for collaboration between health ministries and identity authorities to launch functional identity schemes, which may or may not be linked to foundational ones. It also opens the door to the private sector to innovate health-specific solutions for identity fixing and authentication. This is a rich topic, so stay with us as we look at the role of digital identity in healthcare modernization. But before we start this extraordinary episode, I have a few important announcements to make. First, I'm delighted that we welcomed the new ambassador class for 2024 last month. Alongside this, we restructured the program into multi-agency bureaus, 1 per country, featuring up to 3 high-level government representatives. We singled out 2 stakeholders, the identity or civil registration authorities and the ICT ministries or digital development agencies, who are now required to be represented in each bureau. The third member may come from a user organization or a regulator. We're enthusiastic about the 2024 class, envisioning not only an improved governance body for the movement, but also an organizational structure conducive to enhancing collaboration among stakeholders within each country. We salute the 124 men and women who are empowered by the respective governments to act as emissaries to the movement this year. They continue to serve as liaisons between ID for Africa and their institutions. having already made significant contributions to shaping the agenda and the composition of the delegations for the upcoming annual general meeting. Speaking of which, as you may know, our AGM is set for May 21st, 24 in the beautiful city of Cape Town under the theme Digital Identity as DPI, Fostering Trust, Inclusion, and Adoption. This is a special edition that marks the 10th anniversary of ID for Africa and the ID4D movement. We opened registration on February 15. We unveiled the detailed program and revealed the impressive speaker lineup consisting of over 100 world-renowned experts and practitioners. Please check out the links in the chat to register or to explore the program. I would like to briefly analyze the program to show you why it deserves the accolade of being the ID4D program of the decade. We can start with a temporal view of the program. 3 days of plenaries featuring 13 sessions, followed by 1 day of workshops and forums, with the exposition running during the first 3 days and something we call hands-on AI running on days 2 and 3. We'll come back to this shortly. However, a more revealing perspective is the thematic view. The AGM plenaries were constructed under the following 5 thematic modules, spread over the 3 days. Let me say a few words about each module. First, the Africa report consists of 2 sessions, PS1 and PS2, and showcases digital identity progress from 8 African countries. It goes beyond reporting progress updates, as it will also have what we call the know-how exchange, which is intended to allow for transfer of expertise around specific challenges. We will delve into the decision-making processes and rationale of the 8 featured countries to extract best practice recommendations that others grappling with similar questions can use. The list of topics of this year's know-how exchange is detailed in the program. Second, we have the annual Technology and Solutions Symposium featuring 2 plenaries, PS5 and PS6 on day 2, dedicated to exploring experiences and lessons learned from real-world deployments of innovative solutions. It will examine successful strategies and how to replicate them elsewhere. Highlighted experiences will include insights from Mozambique, Mauritius, Thailand, Panama, and Chile. Module 3 presents the NIST Symposium on the state of the art in biometric performance on day 2, given by 3 NIST experts, whose assessments are relied upon worldwide for making decisions regarding biometric adoption into identity programs. The 4th thematic module, dubbed the Guardrails Trilogy, comprises 3 plenary sessions running consecutively on day 3. They are Digital Identity Governance, the CSO panel, and the Legal Reform Plenary. Here, our focus will be on establishing essential policies aimed at ensuring that identity and digital systems are equipped with the necessary safeguards to promote inclusivity and prevent harm. The trilogy stands as the cornerstone of our discussions this year, bringing together government representatives, CSOs, members of parliament, and development actors to delve into this crucial topic. The 5th module is what we call the next stage proceedings and groups together 5 plenaries spread over 3 days that deal with what comes next in the digital identity adoption sequence. These are a scene-setting keynote on day 1, a plenary session discussing use cases from digital breakaway countries like Philippines, India, Indonesia, and Tunisia on day 1, a session exploring the DPI approach as a strategy for digital development, including perspectives from Uganda, Senegal, Malawi, and Zambia. And then 4th, a session addressing the interoperability of identity data and systems. And then 5th, a session on digital credential management, encompassing topics such as digital wallets, mobile ID, and verifiable credentials. This will be on day 3. On day 4, we will have the interactive sessions consisting of 4 workshops and 4 forums. These sessions run in 2 parallel batches, morning and afternoon, as follows. Morning sessions, we will have the World Bank, W1, Cybersecurity and Digital Identity. That's a workshop chaired by the World Bank. We will have workshop 2, Digital Identity for Refugees and Displaced Individuals. That will be chaired by UNHCR. We will also have 2 forums. First one is Boosting Civil Registration Through Health Twinning, chaired by UNICEF, and then followed by Forum 2, Update on the Implementation and Deployments of the African CRVS Shared Asset, chaired by OpenCRVS. In the afternoon sessions, we will have Workshop 3, which is the Practical Guide to Procurement of Identity Systems, chaired by UNDP. Then we also have a Workshop 4, the nuts and bolts of the DPI approach, chaired by GovStack and CDPI. We'll also have 2 forums. Forum 3, Data Protection and Privacy, the Commissioner's Deliberations, chaired by the Data Protection Offices in Kenya and Uganda. And then Forum 4, which is a session chaired by our academic colleagues from WISER, and it's titled Can Trust Be Engineered? And a fascinating forum. During day 2 and 3, we will also have a feature called Hands-on AI, which is held during the breaks in the networking and expo zone. You can interact with leading experts from ENY on ways AI can boost your digital development efforts. In this zone, we will also have on display innovations from over 110 world-leading solution and technology providers. In closing, I want to emphasize that the AGM program is the culmination of 8 months of in-depth research into Africa's needs and the ID4D agenda through a systematic engagement with all of our bureaus. In addition to sourcing knowledge from within Africa, we assembled breakthrough experiences from the following regions marked in blue. Furthermore, the program fosters a well-rounded, inclusive dialogue that engages all stakeholders. We are delighted to have a significant number of parliamentarians, data protection and privacy commissioners, and CSOs joining our core community, not only as attendees, but also as active participants on the program. Our community is now more inclusive than ever, and the program reflects that inclusivity. The AGM has become the leading ecosystem for the meeting of the minds worldwide, a convening platform that brings together the broadest set of actors in the African and global identity community. There is something in it for everyone, but you need to act quickly and in 3 ways. First, as capacity is limited to 2,000 seats, registration is being done on first-come, first-served basis. So if you want to be part of this amazing experience, do not hesitate. Over 60% of the seats have already been booked. Second, stay tuned to our common communication channels. Put us on your email allow list in order not to miss important updates. Many are telling us that they have seen our emails going into the spam or have been blocked. So please put us on the allow list. Third, if you need a visa to enter South Africa, please apply immediately. South African visas may be running with a delay of several months for some countries. So please take this seriously. Okay, we're now ready to start this episode. I'd like to welcome, in the order of appearance, Dr. Ibrahima Dia, Coordinator, Ministry of Health, Senegal; Mohamed Mahi C, Director, Information Systems, Universal Health Insurance Agency, Senegal, and ID for Africa Ambassador; Charles Yupendoy, Head of the Monitoring Unit, Ministry of Health, Cameroon; Pam Dixon, Founder and Executive Director, World Privacy Forum; Al Shifro, Technical Director, JSI; Bashkar Mishra, CRVS and Legal Identity Specialist, UNICEF; Gemechis Melkamu, Lead Executive Officer, Ministry of Health, Ethiopia; Wayne Naidoo, Technical Director, Gembi Health Systems; Chris Fleming, Partner and Healthcare Practice Lead, Public Digital; Edge Esanj Bedo, Partnerships Director, Simprints; and Beatrice Plaza, Senior Technical Advisor, Vital Strategies. Warm welcome and sincere thank you to all the panelists for being with us. We truly appreciate your valuable contributions to this livecast and to the cause of responsible identity for all. I look forward to engaging with each of you within the different segments. We're now ready to start the first segment. Operator, could you please prepare the panel? For this segment, entitled Digitalizing Health, Challenges and Opportunities, we're pleased to have with us 3 health officials from Senegal and Cameroon, 2 countries that have made health digitalization a national priority and have been mapping out their strategic plans for how to accomplish this for a few years now. We will hear from them what is driving their thinking and where they are in the planning cycle. We have with us for this segment, Dr. Ibrahim Adia from the Ministry of Health, Senegal, Mohamed C. from Universal Health Insurance Agency, Senegal, and Charles Yopendoy from Ministry of Health, Cameroon. The 3 have kindly agreed to speak to us in English to allow for wider audience on YouTube. So we appreciate the extra effort. Audience, please ask your questions in the Q&A platform on Zoom. They will be answered by the speakers off screen, since we will not have time to have interactive questions answered on screen. So after the conclusion of the presentations, you will get your answers. So without any further delay, let me give the stage to the colleagues from Senegal, Dr. Dia and Mohamed. Wonderful.
Mohamed, I can begin?
Yes, you can.
Thank you very much. My name is Ibrahima Alilullah Hija. I'm the director of the Digital Health Department in the Ministry of Health in Senegal. I do this presentation with my colleague and friend, Mohamed Mahisi, and the CDC, that you know very well. They work in the Ministry of Equality. I think that they will present introduce himself after. Me, I work in the Ministry of Health, and we will do this presentation together in order to share with you what we are doing here in Senegal, what is the challenges, what is also the difficulties in order to remove where move to a great health system or digital health system in our country. You can move, yes.
Yes.
Yeah, for Mohamed now.
Thank you, Dr. Dia. First of all, in the health system in Senegal is divided in the 2 sectors. The health sector, the Ministry of Health is in charge of service providers, health service provider like hospital, health center, private practices, health posts, and pharmacies. And in the other side, we have the social protection sector. The social protection sector, we have 3 ministries who are in charge of the social protection sector. The Ministry of Community Development, National Solidarity, Social and Territorial Equity is in charge of the UHC agency where I work. The UHC agency has actually 46 mutuals. The mutuals are the community-based insurance for people from rural or informal sector. And the Ministry of Finance and Budget is in charge of the coverage for civil servant, and the Ministry of Labor is in charge of the insurance for the private sector. Okay, and that's the composition of the health system in Senegal. And you must know, in Senegal, we are actually 18 million of peoples, and actually we are around 50% of those 18 million people are actually covered by the universal healthcare system we have set up in Senegal. Dr. Dia, for the next.
Thank you, Mohammed. You can go ahead, please. Yes, Mohammed said that we are two ministries. We are working together in order to do to transform the health system, and our target is how we can facilitate health care for patients and how also we can monitoring that. The second is very important. It's good to use technology, but it is also better to be sure that technology is available, technology is adapted for our countries. And also, we are doing also better to have a system that is integrating system, that information can be available for all the actors. The last target here is all these two targets can or must help us to have the satisfaction of the patient. We are working for the patient. We are working in order to improve the health system. That's why also our last target is how to increase patient satisfaction and access for health also. You can go ahead, please.
Okay.
Mohammed.
Yes. Thank you, Dr. Jah. And in order to address what Dr. Jah has said, we have many problems, concerns, and challenges that we have to resolve. First of all is the governance. Is actually, as we are working with the Ministry of Health and with all the stakeholders to see how we can bring together our rules to have a good governance of health, of digitalization of health, of course, identification of patient and insured person. So governance is the main challenge. We also have regulation and sanction challenge. Senegal already have a data protection authority and a data protection legislation, but we think it is not enough. It is not enough because in the health sector, we need more protection, not only data protection, but we have medical secrets and other new risks that we engage when we start the digitalization of the health sector. That's why we are working
One moment, Dr. Dia and audience, we seem to have lost.
With the government. The other challenge is to deliver a unique number. And this number we deliver from the health sector must be paired with the number, the unique identification number we have in the social security system or in universal health coverage system. Okay, if we have those two unique identification number, we can connect them both and to address uniquely the patient of the insurance beneficiary. We also have another challenge. Actually, Senegal is working to set up a national digital ID number for each Senegalese. And the other challenge is how we're going to connect those sectorial identification number to the digital national ID number that the government of Senegal want to set up. As you will see later in the presentation of Dr. Jah, we also have the interoperability challenge, because actually we are working in silos. There is many information systems that are working in the insurance sector and also in health facilities. And the other challenge is how to make all those information systems to connect together, to exchange data together. So then if we identify a number, a patient, he can take benefit of service delivery by all the health facility of all the insurance system. We also have a main challenge of data protection and security of data, because when we go to digitalization, we have to digitalize all the pyramids, all the health system pyramids. So we have to digitalize some health facilities who are in rural area or in suburban area, and sometimes people do not have enough knowledge of how to protect data or how data are being used or secured in the system, how to have the medical secrets of the data that they have recorded from their patients. The other challenge is the data storage. If we decide to digitalize the health system, we will produce naturally billions of data. And we have to be sure that our data center that we have in Senegal, the national data center, will have the capacity to store the data we are producing in the health facility system and also in the insurance system. Dr.
Thank you, Mohammed. Can you go ahead, please?
Next slide.
Can you go ahead, please? Yes. In Senegal, we have our first digital health plan in 2019. We have a vision. After that, we have our health system digitalization program that can mean action plan if you want, action plan. And this action plan, now we are our first funding with the World Bank in order to set up this program for digital health. We are working hard with the World Bank, and now the project has begun. This project is not just for health, it's for health and for also the Ministry of ICT. We are working together with the Ministry of ICT in this project, funding by that the funding is providing by the World Bank. The idea is how to set up the 6 great projects that we have here in Senegal, like electronic medical record, telemedicine, hospital information system, health information system for drugs, etc. We have 6 great projects that we are trying to realize here in Senegal with our first $15 million with the World Bank. You can carry on, Mohammed, please.
Okay. It's you again. Next slide.
It's for me. It's for me. Yes, it's for me. Yes. This is one idea of what existing here in Senegal. We have a lot of platforms here. I can say some problems of telemedicine, some platform of electronic medical record. We have also some platforms for drugs. But what we know is all this platform, for example, is not for the Ministry of Health. Also, some project is finished now. Yes, because we don't. When the money is finished, the project is finished. That's why the government said that we need to have a program for digital health in order to organize all this. You can see here digital health, for example, digital health information system, DSS2. You can have open clinic. I don't know if you know that. You can have another system that it is using here, but is locally using. It's not also a system for the Ministry of Health. That's why we have this funding in order to analyze all these and to choice. What can be scale up? What system that you must delay to break? And we are doing this job now with the actors here in the Ministry of Health. I can also just hear a point that now we have begun a great project for health medical record. With the Ministry of Finance, we have a small funding. Now we are beginning medical record here in Senegal in one hospital. And this project is for the Ministry of Health. It's not for the others actors. Is for the Ministry of Health. No, it is for the patients. Thank you. No, the last is for you or for me? The last.
It's for me.
Thank you.
There is 2 slides left.
Yeah.
Okay. So as Dr. just said, we have actually many silos, as you see. There is many silos and many information system working. So our aim is to integrate all this, and our aim is to urbanize all this. And in fine, we want to have a fully dematerialized customer journey. And what we want is, if the patient comes in a health facilities, it can be identified uniquely, even he come with his insurance card, even he come with his biometric fingerprint, or his national identity card, or a QR code, or his mobile, because we want in the insurance system, we are actually building a system that will put the QR code in the mobile. So your mobile, you will use your mobile as to identify yourself in the health facilities. So when you are identified, the prestation is done and the claim processing is sent to your insurer. So actually the enrollment and the registration of beneficiary is already digitalized, and we can generate QR code associated with the insured number. And what we want is to pair it with the patient number that Dr. Jag just said. And we'll have the digitalization of care record and the reimbursement request. And with all those systems, it will be monitored, and you will have your patient file on your mobile, and you will interact directly with your mobile phone. You can interact directly with health service provider. With your mobile phone number, you can take rendezvous to the hospital to see a specialist if you want to see in your mobile phone, and you can pay with your mobile phone, because the mobile phone is also aggregated with mobile payment that already existing in Senegal. And all of this will permit us to have the portability of the system, of the services, and also because we have integrated all the system, and Dr. Gao will talk about this in the next slide.
Mohammed,
yes.
We have just 5 minutes to finish.
Yeah.
We must to accelerate. Permit me to congratulate Mohammed. Ambassador C is doing a good job in his ministry. What he's doing will be connected of what the Ministry of Health are doing. Here, you can see that example of our ambition, of our vision, what we want to do. We have a lot of things telemedicine, but I chose these pictures to show you what we are doing and what we want to do. I want to have one patient. This patient can go in the private health facilities, in the hospital, in the health center, in the health post. And these health workers in these health facilities can see his data and can help him if it is if this patient go in the hospital can see the information, the last information. The health facilities also, the doctor can help him and can do the better in order to give him health cares. When you see that, you must know that we must have identity. We must have identity. Without identity, we cannot do that. We also must have a data centralization. And all this, we are working with the World Bank and with the Ministry of ICT and with Mohammed Embassy C, Mohammed C, and in order to have it in Senegal. Thank you. I finished my presentation. It's for Mohammed. Mohammed, you have 3 minutes.
Okay. Thank you, Dr. Dia. But we will conclude together because we are together. And so, as like the opportunities the system offer, if we succeed in this digitalization and in this aggregation and in this integration, decision makers will have the possibility to have the sustainability of the program. The insurer can increase the coverage of the rate, the modernization. They will have fraud reductions. The health facilities will improve the quality of the care of services and users. The user and beneficiary also will have a better access to information, and they will take benefit of the quality of service. We'll conclude with this last slide of the next step, but for the next step, I think Dr. Ja, we are actually the next step is to make the diagnostic and the inventory of the system of, like Dr. Ja is already doing actually, to see all the systems that are working in the health facilities, and after that we'll make the deployment of the pilot. He already have started the pilot for the medical record system, the patient record system in one hospital, as he said. We also have started the pilot of integrated information system for the insurance system in some area in Senegal. After that, we'll try to integrate the ID, the health insurance ID, with the patient record ID. And if we succeed to do this, we'll start gradually the scale up in the health structure. And after that, we link this sectorial ID to the national ID and to other system. This is the next step of what we are we project to do in Senegal. And I am also really congratulating Mr. Ja also for the job he's doing in the Ministry of Health, and for the good collaboration we have for the benefit of Senegalese people. Thank you very much.
Excellent, excellent. Thank you both for this wonderful overview and for also demonstrating the importance of multi-organization collaboration. This is the spirit of 2024, and we look forward to hearing more about this. Let's proceed to Cameroon and get the report from Charles Yopendoy. The stage is yours, please.
Thank you very much.
We're having some challenge with the audio. Maybe if you share your video, you share your slides, maybe the audio will be better.
Thank you very much, Mr. Chair. Good afternoon, everyone. I was supposed to present on Cameroon digital health I want to say that Cameroon is a country, low-income countries. So with a similar level of development, Cameroon pandemics has raised awareness on the need of digital solutions, particularly in health. During that crisis, and can call it like that, patient was afraid to go to health facilities to get their health. So we find it better to look how to propose remote service to that population. First, running for the period 2020 to 2024. So this plan is monitored by an interministerial committee where we have many actors dealing with questions related to digital technologies and health in Cameroon. So concerning the health system, we have many challenges. The first of all is how to accelerate the achievement of sustainable development goals in 2020. We still have a high rate of maternal prenatal fight to reduce it. We have to stress as acceptable as we need, and we have to enhance self-data system and vital statistics. The other challenge we have is the implementation of universal health coverage. We started with the first phase in 2023, and by the day, we have about 3 million people that has been enrolled. The first phase is dedicated to pregnant women, children aged from 0 to 5, people living with HIV, tuberculosis, and hemolysis patients. And due to COVID, I think we have a development of structures proposing remote healthcare and services to population. And in that view, we have a challenge with the regulation because has their remote platform. So we don't have yet a law that regulates their functioning. And the last is, like all the country with low income, we have a challenge with our technical platform, technologies, infrastructure, our health centers and hospital, and their maintenance. Concerning digital identity, we have a need of guarantee and secure access to healthcare data, both for individuals and for authorized personnel, meaning nurses, medical doctors. Challenges because we need to know who is getting which kind of service where, delivered by who. That's the question we cannot answer as the situation is like as I am describing it now. We need to improve in identity vigilance. That means identification of healthcare providers, patients, and any other key actors involved. We need also to facilitate the control of effectiveness and quality of services provided. What is running on or what is planned in Cameroon in this sector? I can say that for now, we need to strengthen our legal framework with regards to the protection of personal data and the regulation of telemedicine. We have laws, but they don't, the question related to using just like health. So we are still working on it to improve. We need to improve our health data system. We are working with DHIS2. And for now, DHIS2 is able to collect data from about 6,000 public and private health facilities, so that we have a strong database with him, a strong health system, and we have to improve in quality of data. We also need to develop tools days or few months. This question will be interoperability framework for sharing birth and death declaration data, integrated civil status management system. The process is ongoing. Death this one can for
We apologize for the bad connection from Cameroon. Charles, are you able to hear us?
Okay. Sorry for that. Why? That's one of the challenges we are facing here in the country. So I think let me continue here. We're talking, we need to develop an electronic patient file. We are now, as today we have some health facilities, some hospitals who have the electronic patient file, but we need to nationalize that process to be sure that the data collected transferred to the national system, health data system, and share with everyone who want to work on. We need also to develop a master patient index with allocation of a unique identifier. That's still a challenge in our context. We are working on the master facility list for health facility. And also we are constructing 2 data centers dedicated for the storage of health data. We still have that challenge concerning interconnection and computerization of all health facilities, ensuring autonomy in electrical supply and permanent availability of internet. And for now, we are working on evaluation of the implementation of the National Digital Health Strategic Plan 2020-2024, and to develop the new one for 2025-2030. including the National Digital Health Architecture. So the digitalization process in health in our country is still at the, I can say at the basic. We are starting. We need support, and we are working together with all the other administration, with the strong leadership of government by the project e-government, to make sure that by maybe 2030, all our health facilities will be connected, and we can easily collect and share data that are reliable for all the system. Thank you very much.
Thank you, Charles, for this overview. Just a very quick question for you. Cameroon does not have any data privacy laws passed yet. Is that correct? Just to clarify.
We have laws. We have a law for electronic telecommunication, but we are now working on a law on personal data protection. So the process is ongoing.
And will there be a health-specific law, or this will be a general law for all personal data?
General law for all the country, all sectors.
Do you have any timeline about when you expect Cameroon to pass such a law?
I cannot. The process of validation is ongoing. I cannot. Okay. Maybe by the end of this year.
Maybe by the end of this year.
Maybe we can have the law.
Okay. Thank you very much for both of the countries participating in this segment. As you can see, Senegal and Cameroon, there's a lot to be done. This is not just simply doing an identification project. We apologize for the bad network connection. Anybody who wishes to receive the presentations because you were unable to hear, please send us an email, and we will be happy to share with you the content. Okay, operator, I want to move on to segment 2. We're now ready for segment 2. And as we have just seen from segment 1, digital health is a substantial topic. It goes beyond identification. You have to build data centers, you have to integrate information systems, you have to integrate clinics. It's just not a simple task. But within it, all of this, digital identity plays a very crucial role. I think no one would argue with the fact that health ID is a necessity, so we can take this as evident. But the question at this stage is what forms of ID or identifiers are optimal and safest for health to rely on, and what are the implications for each choice? I should emphasize that despite its significant role, no standard or best practices have been officially established yet by any UN health organizations to guide the selection of health ID or identifiers. This should give you an idea about the complexity or sensitivity of the topic, and in fact, that no one size fits all. We, as the identity community, should be ready to assist any health organization that seeks to fill this gap. In the meantime, let's delve today into the intricacies of this matter. With us for this segment, an operator, please bring them to the stage, Pam Dixon from World Privacy Forum, Al Shifra from JSI, and Bhaskar Mishra from UNICEF. Okay, welcome again. I'd like to start with the current situation in the health sector, your view of it. I'd like to understand the complexity of the health ecosystem. How are patients currently identified? We hear identification in health is problematic. In fact, the first 2 speakers have really confirmed that. But so let's try to really analyze why. I want to start with Bhaskar. Bhaskar, you conducted some research recently about the proliferation of health identifiers, and you mentioned some interesting numbers about how many identifiers you have encountered used by different health programs. Can you share with us what you saw about the different identifiers used and how that ecosystem has, what implications that ecosystem? Don't give us the solution, just tell us what is existing today.
Thank you, Joseph, for the opportunity. So let me give you two examples. So when I was working in Tanzania, when I joined in 2016 March, there were close to 125 systems and subsystems within the health sector. And when I left in 2021, from 125, it went up to 142. Last year, I led a joint mission to Nepal, and you'll be surprised that, I saw the same fragmented system. So if you were a Nepali and suffering from, say, 3 diseases, HIV, TB, and malaria, then you would have 3 distinct identities, okay? And these identities don't talk to each other. So it's a problem of, plenty versus none. So a person might have more than one legal identifier, okay, unique identifier, or he or she may not have any.
Okay, so, and this is not specific to 1 or 2 countries. You're seeing it in the development context as basically everywhere.
Exactly, in most low and middle income country settings, this is the situation.
Okay, let me move on to Al. Al, you have been working in Africa, and so what do you see today in terms of how health services identify their patients in Africa within the development context? You've been an actor in this space for a while as well. So how are they identified today?
Yeah, so as previously mentioned, the problem is really quite widespread within the health sector, but it's really true that it's also the case in other sectors. So in the case that that I've seen in various African countries is there's not a unique identifier that health programs can use to uniquely identify patients. We tend to have a lot of vertical programs, but the good news has been a lot of these vertical programs are slowly going away into supported by system strengthening, and that would allow us to plug in a foundational identity at a lower level, at the foundational level that these functional systems or these vertical systems can use. So to the example my colleague from UNICEF just mentioned, as long as the problem is with the way that these are structured and are architected. So the identity should be a foundational piece. Therefore, when there's an HIV system or an insurance system to look back at the previous presentations, they're not creating their own identity, but they're actually feeding off or building from the foundational system.
Okay, that's fair enough. So we want to do first situation analysis, then we look at the options that are available. Pam, I want to come to you. You've been very active in the global north with the health sector, especially in the US. Give us a sense of how patients are identified in the US, for example.
Yes. So I want to be clear. I also do a lot of work with the World Health Organization and have for some time now as part of the Nepal mission and the governance in the, yes, anyhow. So in the global north, the health identity systems are quite fractured. However, some of it is intentional at this point. At one point in time, about 15 years ago, the health system was less fractured. A unique ID was used primarily to identify patients across the board. And this was in a highly digitalized system, and the silos were broken down. But unfortunately, what was happening is that patients were experiencing profound amounts of fraud. And I testified before a congressional subcommittee about this in, oh my heavens, it was 2004 or 2005, and then subsequently wrote a report about how people were literally dying from this problem. So what has happened in the interim from a lot of work is that the unique identifier was removed from the provision cards in the US, and the sectoral IDs were used instead, as well as state level or subnational IDs. And then these were crosswalked in an extremely secure way that was not accessible to providers and other entrants on the scene. The basic problem is this: in a highly digitalized system and a complex ecosystem, you literally have thousands of points of contact with the patient ID. And if you use just one patient ID that cannot be regenerated after fraud, you will have patient misidentification as well as patient mistreatment. And this is all preventable with advanced planning. It's not easy.
Yeah.
ID in the health system is not easy, but it is possible.
Okay, hold on. I don't want to yet look at the sort of pathways and solutions. What I'm trying to understand is in the global north, for the most part, in some countries like the US, and we're going to hear about the UK shortly, you are not using a foundational ID system, and that in fact there is multiplicity of health identifiers. And you're saying it's actually by design. It's not necessarily that we have one unique identifier in the US, for example. Would you say that that's correct characterization?
It is absolutely correct. It is by design. And it actually cost the US government over $1 billion to create this design, to remove the unique identifier from the provision of health. So yes, by design.
So we actually have two situations. Both are fragmented. In the like the US identity systems for health are highly fragmented, and you've got also the developing context, low and middle income countries, where it is not by design, it's by de facto reality on the ground. So we do have fragmentation, and what I'm hearing is that fragmentation is bad, but also there is a certain type of fragmentation that may be good. So let's try to dig in and try to understand the subject better. So I promised you, I said, this is not a one size fits all. You can't get one answer to be the correct answer. There's no right or wrong. So, but let's pull back. Let's pull back and look at one thing. When we look at all the use cases of digital identity, you know, we've got social protection, we've got health, we've got finance, we've got immigration. So we've got a lot of use cases. Do you really think, and I want to see in what way, the three of you, do you think health stands as a special use case of digital identity? And if so, why? And be brief, please, Pam, and I'll go backward. So
the answer is yes. So when I did field research in India on Aadhaar, it is very clear that when India went digital with their health ID, there were a lot of problems that ensued. So yes, digital, yes, ID, but it has to be worked with, and it's going to be highly contextual. So yeah, fragmentation is important, but it has to be dealt with.
So basically, don't think that health is just a replication of financial sector. The health is very special, it stands alone. We're going to come back to that. Al, how do you see health as a use case of digital identity? Are we exaggerating when we say health is very special?
Not really, but I'd be very brief. So I've been thinking a lot about this, and it's very difficult to look at health as siloed, even though we like to think of it from that perspective. So there's a huge use case for health within the health sector, as mentioned earlier, with a lot of touch points, with finance, as you mentioned earlier, with insurance and social protection. So in that aspect, I think it's quite unique. It allows us to solve the problem within the sector, as well as prove digital ID could be a solution for a societal value.
Okay. Bhaskar, do you want to add to this concept?
Yeah, so, the health has the longest history of working in this area, because they have been trying, almost all countries have been trying to do something. But the starting point has to be that, within the health sector, they need to converse, how do you connect all systems and subsystems? Okay, because that becomes a main problem. And then finally, once you have a unique identifier for the health system, then we can think about converging this with the national identifier, and there are ways of doing it. Of course, there are concerns, as mentioned, we know what happened in South Korea in terms of data leakage and all. But given the ground realities in Global South, I think, they will have to have an approach where the health sector has to, the sectoral and subsectoral identifiers have to converge, and then we need to find a way of converging with the national identifier. That is the way forward.
Now, Al, do you really think that one patient, one ID, one lifetime is the right approach that we're going to head towards?
Mm-hmm. That's an excellent question, Dr. Atick. I like to believe that I think we got to center this along the personal choice of the patient. So I think the idea of a health ID does not necessarily link to a foundational ID as long as it is there by choice. In other words, I think we could look at India as a model. You have a health ID system, but the patient can choose to link it to the Aadhaar system, or they can link it to the passport or other forms. So I think It's quite important, especially when it comes to health, given the sensitivity around it, that we give the patient the option to opt in. But ideally, that's kind of the way we like to go. And the other thing I'd like to add is absolutely important to have virtual IDs linked to health IDs to provide additional level of protection around privacy of data.
So Pam, beyond the linkage to foundational or legal identity, I'm more talking about digital multiplicity. I mean, when we look at our footprint on the internet, many of us have 20, 30 digital identities. We have identity with Google, identity with Apple, etc. Do we think it is going to be necessary to have one identity to rule them all for health, or can we really function having multiple digital identities? I'll come back to the question of linkage or no linkage. What is your sense? You've seen the dangers of one identity to rule them all.
Well, look, if you look on the ground in various countries, the health ecosystem is much, much more complex and mobile even than the identity ecosystem. Think, for example, of travel. If a person has crossed a border, they're not going to be in that health system of that country. What happens then? You can't have a national ID necessarily that skips borders or skips to a totally new jurisdiction or region. There's always going to be multiple identifiers in the health sector. And it actually can end up being a feature, not a bug, because you'll have insurance identifiers, you'll have various identifiers. And when there is fraud, and the more digital a system becomes, the more fraud becomes present. You really need to be able to regenerate numbers and to work very carefully with the electronic patient record, which is part of digitalization. So there are administrative ways of handling these problems. You don't have to have one ID to rule them all, so to speak.
Okay, all right. So basically, we are leaving the option open that there could be a digital multiplicity of the health ID. Okay, but the question that I want to raise now to the three of you, and I'd like a straight answer. I want you to select your camp. There are three camps. I'd like you to select a camp so we can develop the dialogue around this. The options, do we link directly to the national ID, foundational ID? So this is a derivative of the national foundational digital identity system. That's option one. The second one, link indirectly to the national ID, which means tokenized foundational or virtual, if you like to call it that way. And then the third option is completely independent ecosystem. It's a functional ID, could be a serial number, it could be a full-fledged biometric-backed digital ID, but it has nothing to do with NID, and you could not even find a place to link it. So you exist in a parallel universe. So I want to ask the three of you, I know this is not a fair question, but we want to make the conversation a little bit more interesting so that we less overlap between the three of you. Choose your camp. Pam? 1, 2, 3.
Okay, I'm choosing option 4. So I think a blend between the indirect link and the independent ecosystem, because there are certain areas of health, such as genetic testing and genetic diseases, that require some independence. Okay. So there are little carve-outs.
I'm going to put you in 3-star. Okay.
Okay.
Bhaskar.
I will go for a mix of 1 and 2, like first and second. And especially I'm talking from the lens of, like countries in the global south. Okay, and what I have seen on the ground, I can tell you both sectors, like health as well as national ID, because most countries that you see in, like in the global south, they neither have complete UHI nor complete UIN. Okay, so it has to be reinforcing, like they have to work together, okay, because they haven't reached a level where you have, like 100% coverage of UIN, and then you can think of doing something. So it's going to be a mix of option 1 and 2.
Okay, so 1 star. Al, where are you in this?
All right, yeah, quite interesting. I would say number 1 is a no for me because of the risk. I think we talked a little bit about safeguards and data protection and privacy in place. I'm glad you asked that question on the previous slide, in the previous presentation. So 1 is too risky. 2, derivative of ID, using virtual IDs linked, that makes a lot of sense to me.
Okay.
The reason I'm not going for number 3 is because I mentioned earlier, health is not just siloed, it needs to work with other sectors, and that would make it it's used very limited. So it's really number two, but it very much possible would be ideal if we can not force people, but encourage them to opt in.
To opt in. Okay, actually wonderful. So each of you lined up 1, 2, 3, whether it's derivative or not. I didn't even preview this with you. So I'm glad it ended up being that way. That means that there is no wrong answer. There's no right answer. There is answers depending on the context. Bhaskar, you raised an issue which is quite interesting. And you said that the answer does depend on the context of the development. In a development context, you would lean towards a 1-star, but perhaps in a highly developed global north context, perhaps you would lean somewhere else.
Exactly.
Right. Okay. So we gotta look at the state of development of the countries, because managing tokenized numbers is not necessarily simple for the consumer, simple for the patient. I want to come back to Pam. Pam, you've written so many articles on the harms of direct linkage of health ID and NID and national ID. Can you walk us through some of your findings and what your argument is based on?
Yes. I think the most challenging example I ever faced in this area was in India. I lived in India, as you know, to do field research on Aadhaar. I began living there in 2010, and I lived there off and on for over a year and then went back and forth until around 2016. So during that time, I spent my time really interviewing as many people as I could. I talked to as many stakeholders as I could, including very vulnerable members of populations, such as victims of human trafficking. And what happened is, as the Aadhaar ID became more mandatory within the health sector, in fact, it eventually became mandatory prior to the Supreme Court decision, what was happening is that women and children who were victims of human trafficking, who had been kidnapped and brought to India, were being forced to get an Aadhaar ID prior to receiving medical care. And what was also happening is they were being forced to stand as witness to prosecute their traffickers. All of these are deeply ethical, deep ethical problems, and it really needed to be solved. This is not how to treat vulnerable members of the population. And this was just egregious. Now, there were some very, very important Indian researchers and jurists who were working on this problem. I worked with them, and it has been solved now. This problem has been solved. There's tokenization. This specific problem has now been solved. But this was a terrible situation for a lot of people for several years.
So, and it resulted from the obligatory linkage between health ID and a unique national ID.
Yes, it was, look, linking a national ID with a health ID is not done out of negative intent. This was well intended. It was not meant to harm anyone. But when you scale a digital ID system and link it to a scaled digital health system, really difficult unintended consequences occur. And that's what happened here. It was not foreseen. And we just have to keep in touch with the stakeholders and look at what's happening on the ground, not in theory. The theory is great. Trust me, I believe the theory too. But in practice, it doesn't actually work that way. We have to be careful to match the practice and then go to the theory, as opposed to the other way around.
Okay, fair enough. Al, and then I'll go to Bhaskar and Pam on the same topic. Having a unique single digital health identifier attributed and associated with data, does this give you any moment to pause thinking about trillions and trillions and terabytes of data, honeypots sitting somewhere? Wouldn't that be starting to attract? This is the question of centralization of systems. When you remove fragmentation, you're necessarily creating either a virtual centralization or a physical centralization. We've heard from Senegal, for example, they're talking about how are we building the data centers to house this. Does this give you concern? Is this the right strategy? Should we be building honeypots of medical data somewhere, all labeled nicely, or should we really move towards decentralization of data? I mean, give us your sense.
Sure, yeah, great question. I'm glad actually it was raised, because I think this is quite important to stress that when we talk about identity, we're only really talking about providing the various MIS systems across the health sector an ability to uniquely identify the patient, not necessarily data about the patient or whatever the specific health information is. So I think it would be a risk for ID to start to capture information outside what is really going to be needed to identify a person. So I think in my perspective is ID should stick to specifically on those attributes that provide uniqueness to the various systems. And when it comes to
of data, that's not my question. The centralization of data is a byproduct of the fact that you're using the same number, which is yes, ID is ID. But if I'm doing cancer monitoring, I'm using pandemic monitoring, etc., and they're using the same identifier, somebody is going to be able to consolidate this data somewhere. No,
right?
It's not the ideal of data.
And that was my rationale in choosing number 2 when it comes to virtual numbers. And even then with opt-ins, right? And secondly, countries across Africa are working on health policy, which is trying to define as to what kind of data could be stored for how long, how much of that data can be aggregated, and so on. So one thing that that's becoming more common is when it comes to health policy decision-making, what's being shared is aggregate data, not necessarily individual data.
Okay, but let me go to Bhaskar and look at how India, for example, is trying to deal with health data. For example, you are getting a locker and you can keep as under your, instead of having a national consolidated data, every person captures and saves their own data. They're responsible for their own data. Is that a model that you think a development context can work?
It can work, but please try to understand the ecosystem India has managed to develop, and that would, African countries will take maybe at least one more decade to reach to that level. Okay, and coming to Pam's question, a couple of years ago, Aadhaar has come up with that 16-digit proxy number, but I can tell you by that time, not less than 100 copies of my Aadhaar card, was circulating everywhere. Okay, because in India, you cannot survive if you don't have an Aadhaar card.
Right.
Okay, so now these guys, they have learned, they're trying to make corrections. But the main point, Joseph, is, and I'll go back to, my previous stipulation. The idea is we should see this, the choice of sectoral versus universal from the lens of complementarity, not adversity. Rather, I would say this is a necessity, especially in Global South. And also we should know that countries will have to live with ground realities and they build on top of what they have. And certainly with a well laid out approach, sectoral identifiers can merge with or lead to unique identifiers, of course, with a lot of safeguards on data protection, privacy, and also in terms of, how you store data. Like, for example, for cancer registries, even if we have a client registry, there's no need to store, those sensitive information as part of the client registry. So you can have those safeguards. But my moot point is that, we have to be practical. Let us come up with practical solutions that countries can adopt and move ahead.
Okay, fair enough. Pam, what does the consolidation of data give you as concern? And also, how do you feel? Do you really think privacy by design for health data can work?
There are a couple of answers to your question. I'll be just as direct as possible. So
Please.
First, the transactional exhaust issue in the health ecosystem is very substantial. Every health interaction creates some kind of digital exhaust. It's going to go somewhere. If it's gathered under an ID, it needs to be handled with the utmost of confidentiality. This is what Ambassador C was talking about, was really the legal confidentiality of the information, as well as protections for human subject research. These are global norms. They are not restricted to the global north nor the global south. They're global. And these are quite important values to insist upon. But there's something to think about here in regards to your question, which is implementation. If there is a single point of error in the 1,000 or more entrants to most health ecosystem, even the small, most simplest ones, then that person can be misidentified within the health sector. It happens on digital, it happens on paper. And to think of the work involved in permutating this ID through every single point of contact with every patient in a country is extraordinarily challenging. I don't know how one can get past that It's really tough. That's a really tough point.
But in creating these honeypots of data, do you think we're also creating temptation to sell medical record data?
Yes, this has already been proven. We have multiple use cases here. There are profound use cases in the US. There are profound use cases in Thailand. There are profound use cases in South Korea. Most jurisdictions which have digitalized their health sector already have this use case. And the question is within the context of that region, that country, that health ecosystem and their level of development, how do you prevent that? You're going to have to find a way to disaggregate the information, give patients more control over their electronic health record, and find ways to secure the data. But if you have it in one centralized location, it's not really going to be possible to secure. And we haven't mentioned this yet, but we really do need to mention it. And that's this. When you look at the financial sector and even identity authorities and their ecosystems, their focus is on protecting the ID and the number and the data associated with it. This is correct. In the health sector, this is not the focus. The focus is on saving people's lives. You have doctors. They're trying to save people, not the ID number safety. So there are tons of leakages, unintentional, but it happens. In the healthcare sector, it is a horse of a different color, and we have to respect that and understand that we have to work around that context.
Okay, so in the last few minutes left in the segment, I want to ask the three of you, starting with Bhaskar, if you are advising a Ministry of Health that wants to use identity and wants to link it to whatever, what doesn't want to link it, give me a pragmatic set of recommendations for how the health identifier should be done.
So I will say the starting point should be setting up a client registry. Okay, so that when a person visits a health facility, his or her basic biographic details are captured and a unique health identifier is issued after due validation so that duplicate records are not added to the system. And the key is to make the client registry compulsory, including existing clients across age groups and systems and subsystems. And on subsequent visits, like his or her credentials can be verified or searched using name, date of birth, registered mobile phone number, or even unique health identifier. And at the same time, I would say that the specific systems such as HIV, TB, cancer registries can collect sensitive information, and that should not be linked because of data protection and privacy issues. And in due course, existing client sectoral identifiers will be mapped to unique health identifier. Once mapped, the sectoral identifier will be subsumed, and there are different ways of doing it. But this process will take maybe even a few years to include everyone. So it's not going to happen in one day, but there are certain prerequisites. Just give me half a minute, okay? The first is that the client registries will be rolled out nationwide. They should sort out the logistical issues. And the most important one, and Pam would agree, a mechanism should be put in place to protect sensitive data, addressing the human rights aspect.
So you'll be advocating that they look into the ecosystem of a master patient index, essentially, and link it to legal frameworks that protect the access and defines the use cases of that. Actually, we're going to hear about master patient index in the next segment, which is coming up in both Gembi, the health systems, and Ethiopia. So we'll hear a little bit about that. Okay, Al, what would you tell the minister?
Right. So three things. First and foremost, this was mentioned already, is to have some form of legal framework that provides protection for the patient, as well as ensure that there's accountability for facilities who might abuse data. Secondly, identity should be a shared resource. That shared resource could be within the sector, but then the sector itself could be indirectly linked with the foundational system of the national identity system. Again, should be opt-in, should be virtual numbers, and so on. I do not believe that health ID should be strictly linked to national ID systems by mandate. And that's very important because, the patient choice is really important. One thing I'd like to add, however, though, is I think the previous discussion, I think we were mixing a lot between health data and health ID. I think identity should focus on identity, and health data is its own beast with its own sector and policy and legal
Yeah, but the problem is if health data is tagged with a unique identifier, it becomes sensitive health data.
Yep.
Exactly.
You know, so that's why there is an intersection between them. But fair point. Good to have those recommendations. Pam, the final word is yours.
Thank you. Okay, here are the steps that I recommend to the ministers. Number one, map your ecosystem and map it really well. You need to know what's there before you can prescribe anything. Secondly, know all the points of contact where you have contact with that ecosystem, and I think it will surprise you because there will be thousands, even in a small jurisdiction. Thirdly, consult with all of your stakeholders, including vulnerable populations and people who are living in poverty who may not have a voice otherwise. Fourthly, ensure that the differences between the urban ecosystems and the rural ecosystems are taken into account because this creates a lot of friction and it's important. And then select several systems that might work for you and test those systems in pilot projects. Don't just choose one, choose a couple, test them, ask people, and then use the results of the tests and talk to people, but also talk to your healthcare providers and get everyone's input. Get inputs from your stakeholders, and then work with the legislature on the ground to ensure that good healthcare guardrails and privacy guardrails are in place, as well as data regulations that control the cybersecurity aspects of this, because fraud is an issue. And then, of course, 2 final words: do no harm and provide a public good. And then finally, trust. Trust and trust. Patients and providers both must trust this ecosystem. If they don't, your goals will not be achieved. People are trying to help improve patient health, but you must have trust in order for that to happen.
Okay, well said. I mean, this is a rich topic. I don't think we will only treat it once and that's it. I think it's an ongoing topic of discussion. I think with a very high probability, this will be one of the themes and the topics that we will address at the AGM in 2025. So that would be an important ongoing activity. Of course, I've invited the community to tell us if they think health should be an ongoing area of concern for us. And looking at the number of attendees live and attendees on YouTube and the number of people registered, I will think I've got my answer already. So thank you so much. We could continue this, but we have other segments to go to. And so thank you for that. And operator, I'd like to start the patient identification segment, which will consist of 2 keynotes, one from Gemechis from Ethiopia, Health Ministry, and then the other one from Gemechis. And so Melkamu, Gemechis Melkamu will share with us how Ethiopia is actually trying to address this challenging issue of patient identification, which we just had a discussion around theoretically. So now let's talk about how Ethiopia is doing this. And then we will go to Gemechis, who will give us their vision of the platforms that are being developed to make this process meaningful and resolve some of the issues. So Gemechis, please proceed. The stage is yours.
Okay, thank you so much. Maybe
Gemechis? Yes. Can you speak, please?
Yes, can you hear me? Okay.
Yes, we can. Please proceed.
Thank you so much for this opportunity. Just I'm going to present leveraging the digital health identity for healthcare. My presentation is very short. So in my introduction, as well known that Ethiopia is the second populated country in Africa with a population of 120 million, and we have so many facilities, around 4,400 health centers and hospitals, and there are about more than 70,000 health posters. These are the government health facilities. It's a huge health service. So regarding the national the patient identification is also the use of this identification is mentioned in Sustainable Development Goals. So implementing accurate and inclusive patient identification system is essential for advancing global efforts to improve the healthcare access, qualities, and equities. So based on that, it's so important to implement the unique identification in the healthcare. The other thing is, as a ministry strategic approach, the unique identification is the key strategy for the ministry to lead the information revolution, implementing the digital blueprints and to achieve the health sector transformation plan. The patient identification is a very important and critical one. So regarding the health record management, also the digital identity is very important. So it's very important to enhance the patient data tracking system. Currently, our system, we are using the manual one. It's not easy to track patient records across facilities. So having the patient identification is so important to track the patient's data across facilities. So this is very important. And the other thing is it increases the efficiency of health record. So the digital identity is very important to increase the management of patient records. And also it is so important to integrate the systems, since we have different systems, point of care systems. So having a different identity is so difficult to integrate. The digital platforms currently we have deployed in the country. So the other issue we recommend the digital ID is it's for the digital ID so important for digital health credential. So to secure the access and to verify the real time of, especially during the service. This one is very important for audit trials, for the accountability, for role-based access, for the compliance and regulation, also for remote healthcare services. The digital identity also is very important. So regarding the advancing inclusiveness healthcare, patient identification plays a critical role in advancing inclusiveness healthcare by enabling equitable access to quality service for all individuals. So that's why also having this unique identity is it's very important in the implementation of health or in the delivery of healthcare. So that's why we are recently focusing on this area. In another case, revealing emerging technologies in healthcare, like the AI diagnostic, artificial intelligence, telemedicine, electronic health record implementation, mobile health technology for data analytics, for the surveillance issue. So while implementing all these technologies, the unique identification also is very critical to enhance the implementation of all these solutions. So the opportunities to implement this, there are opportunities to deploy the unique identification or the national IDs. So because of many reasons, for example, we have health extension workers who are working in the community area. If you are going to implement the national ID or the patient identification, we can use health extension workers as advocates. There are more than 48,000 health extension who are working in the community level. So we can use as an advantage. The other thing is the health insurance program is one of the great, they are currently working strongly. So they have many members. They have already registered a lot of members, the part of health insurance. So this is another advantage. Also, the other advantage is currently we have implemented the human resource information system. So through this system, we expect around more than 400,000 health workforce will be registered to this system. So when we integrate the national ID or identification to this system, it will be so important. The other thing is strategic patient awareness. At yearly, more than 143 million patients will visit the OPD. So creating the awareness on this area to use patient identification or identification is one of the very critical area. So the other thing is we have, in terms of technology, we have connected most of the facilities. We have around 4,000 health facilities, and different hierarchy of the health office are connected to the health net. And we have also a national data center. Even recently, we are planning to have deploy or develop, build 7 data centers or hubs in the country to interconnect all the facilities to these 7 hubs. So these opportunities are they are enablers to start the use of national ID. In another way, there are many challenges. Because of we are not using the national ID, we are having the duplication of patient data and the fragmentation of data because we are using different systems. All these systems are not properly read each other. The flow of data across the systems are not smooth because of the patient identification is not implemented yet. This has an impact on the lack of continuum of care, especially in some programs. It is lack of monitoring, like on the vaccine management and other areas. So another opportunity is recently the new proclamation about national ID is already endorsed and already in the implementation. This is another advantage. The other advantage is we have developed and endorsed the digital health blueprint. In this digital health blueprint, we have mentioned the use of the importance of the patient identification. So now when we are going to the implementation, it is one of the it's also one of the advantage. And also we have developed the electronic health record system, HR standard. Also in this HR standard, we have also already mentioned the use of having the patient identification to minimize the duplication of the patient data. The other good opportunity, we have implemented electronic community health information system across the country. This is an Android digital platform, which is used to support community level health information system. It is implemented in around 8,000 health posts in the country. And using this platform, we have registered around 25 million people's information by this platform, and more than 5.6 million household profile and information is registered. When we integrate the national ID or patient identification to this platform, maybe it's improved the data quality across the community level. The other thing also, we have started the biometrics technology for a specific program. We piloted in 7 waradas in the country. And this is specifically, we are using this biometrics for the program TT surgery. And it reduced the risk of false reporting and promoting data accuracy on this area also. This is another good opportunity. The other thing, we have implemented electronic medical record system in selected few hospitals. It's because of a resource intensive project. We have 3 different softwares are expanded in the country. One is Pahamin Open MRI software. We started implementing in 34 health facilities and 29 hospitals. And the pulse care, mostly in the capital city, it is deployed in around 23 health facilities. And electronic AMR ART is implemented in more than 820 facilities across the country for specific ART program. So while implementing all this, we are just using a fragmented identification. But now what we are planning is to have a standardized and single patient IDs to integrate all this. And the other thing is the CVHI program is implemented in the country, the community-based health insurance in around 1,000 districts. About 12 millions of households are registered, and there are 56 million beneficiaries are registered, and more than 6 billion revenue is collected through this program. So when we integrate the identification, it may solve a lot of issues happening on this area. Accurate member identification, streamlined enrollment process, and other issue will be solved. So the other thing, as I've mentioned, around more than 100,000 human resource for health are registered on the IHRI software. So when we integrate the national ID or any identification we choose, finally we can easily identify the human resource across the health sector. The other thing, we have recently started the Wellness Pass project, the Patient Smart Card project. We have selected on 2 use cases. Previously, it was started by COVID vaccine tracking, and recently we have integrated the written API program, and we are piloting in few selected health facilities. We have already the procurement of 2.4 million cards and tablets are purchased and distributed to those facilities. Then the program is now on pilot stage. We are planning to integrate the national ID or identification number, standardized identification number to this platform. So finally, what we are planning is currently we are working with the FIDA number with Ethiopian National ID, and we have collaborated with them. The MOU is signed with the Ministers of Health. The technical working groups are established, and they are strongly working on this area. So now we have started the interoperability integration of the human resource information system with the national ID. And the next we want to integrate with other digital health platforms. So these are my presentation. Thank you so much.
Thank you. Thank you, Gemechis. Actually, I'd like to ask you a couple of questions. Can you explain your identification strategy if you have already established one? Because you said you're going to be using the national identity number, and then you said there is also a health ID card, that's smart card. So what is your identification strategy?
Thank you. Yeah, for now, just previously we don't have the unique identification, standardized unique identification. So, but recently we have started working with the national ID program, and we have established a technical working group. So through those technical working group, they are more investigating how we use the national ID for the patient for healthcare. So still just we're discussing for now, but we are selected a few use cases and start integrating as a pilot test.
But is it fair to say that you have not really decided to use the naked national ID number, the FIDA number? Could be a tokenized version, or could be a derivative version, or will you just use the number as is?
For now, just we are technical workings are working on this area for the decision, but we want to test the national ID with human resource information system. If that is feasible and functional, we may continue for other systems. or maybe we can choose another alternatives.
Okay, so you will base your ID on the national ID, foundational national ID, but the
Yes.
specific way by which you base it is still under study by your working group.
Yes, yeah. Currently, we have completely based on the national ID, but the study will continue on this area.
Okay, and explain a little bit more about this health card. You said you're ordered 3 million of them. What is the role of the health card? Will it be an identifier as well, plus records, or how are you seeing the health card playing here?
Yeah, the cards are primarily designed to manage the data portability or the patient information portability, mobility across the facilities. So for previously, if someone is take a vaccine on a specific health center or hospital, he has to finish the rest of the vaccine there. But at this time, they can take a vaccines. It's facilitates the continuum of care across the different hospitals or facilities.
Mm-hmm.
So it's on the pilot stage. Maybe in the coming time, we want to integrate other use cases as well as we need to use for different purposes as well.
So is it fair to say that you are in the process of building a data strategy, because at the end of the day, maybe accumulation in a over the cloud in a honeypot might be dangerous and difficult to protect, but you will be exploring distributed data, health data through the smart card platform that you're building?
Yes, yeah.
Okay, so you are aware of the issues associated with the centralization of data. So it would be interesting for us to hear, what is your timeline for testing the smart cards? And sounds 3 million sounds to me more than a pilot. You're doing a deployment.
Yes, yeah. Yeah. When we have currently we have already distributed or implemented on around 6,000 people start using the card. So within 1 year, we want to reach this number around 2.4 million.
2.4 million. Okay, very ambitious. Okay, so to the audience, if you have any questions for Ethiopia's health ministry and you would want to know more about what they're doing, or you want a clarification, please ask them not in the chat, but in the Q&A section. And then Gemechis, we would love you if you could answer some of those questions off screen if they come in. Okay?
Okay, thank you.
Thank you so much. Thank you so much for the time. Operator, we are going to continue with the second keynote, which will be from Gemechis Health Systems and with Wayne Naidoo. Wayne, are you with us?
Yes, I am.
Okay, welcome, Wayne. The stage is yours. Thank you.
Excellent. Afternoon, everyone. Thanks for the opportunity to speak at this event. So I'm Wayne Naidoo, Technical Director at Gemechis, and I'll be sharing some of our experiences around patient identity management in health. So just a bit about who we are before we begin. Gemechis is an African nonprofit, and our focus has been on supporting countries primarily on the African continent, and more recently in South Asia, in countries like Indonesia and Sri Lanka, in realizing their vision for national scale integrated health information systems that ensures continuity of care, as well as accurate public health surveillance and reporting. We're also founding members of global communities like OpenMRS, one of the largest open source EMRs in the world, the OpenHIE community, which aims to guide global design of national health information architectures and implementations. And Gemechis is also behind the OpenHIM, an open source interoperability layer solution, which is also a global digital public good. So for today's presentation, we'll start the discussion with an overview of some of the challenges with patient identity management that stand out in healthcare. Then we'll define and clarify what was already referenced prior in the previous panel, an MPI, a Master Patient Index, and what that is and why it's such a key component that can respond to some of these challenges that's been discussed. Flowing from that, we'll point to key capabilities of an MPI, enabling its response to the mentioned challenges. And then we'll close with some of our more recent country implementation experiences, highlighting the patient identity problems on the ground that are being tackled at the moment. So to get started, we note that patient identity management is actually an integral part of healthcare. We identified two high-level use cases that experience identity management as a pain point. Firstly, there's no continuity of care without identification of a patient's records. Consider the actor care provider. How can they retrieve a patient's care history? And this can be the context of a patient visiting a single facility and accessing multiple service points or moving between multiple facilities. Secondly, health program reporting typically is skewed by duplication of patient files across siloed systems. Note that strategic decision-making is based mostly on patient counts. Again, consider the actor a strategic decision maker. How do they access accurate, deduplicated reporting? So let's lift out the need emerging, accurate linking of patient records across disparate data sources. Next, I'd like to highlight that patient identification is highly siloed in public health systems. Again, this was brought out in the prior panel. Consider silos of patient identification at multiple levels. Firstly, at the facility level, even within a facility, different departments typically can repeat patient registration to open their own file for that patient that is accessible to that department. Between facilities, interfacility, a patient roaming from one facility to another will often repeat registration to open a new file. Thirdly, it's common for disease programs to have, because of varied funding sources and technology partners, we often find the building of siloed identity management systems that is specific only to that disease, for example, the HIV or TB program. Then there's also multi-sectoral use cases. Consider a nutrition intervention, needing data from sectors other than health, such as the Ministry of Food or Education or Water and Sanitation. And then lastly, the prospect of cross-border international travel will encounter the challenges of countries having their own independent ID systems. So the keynote, data retrieval linked to a chosen patient is not possible across each of these different contexts without a common identifier. Again, let's lift out the need emerging for a unified patient identity strategy across different contexts in the health sector. When thinking about what identity system to get behind, it's important to consider how strong an identifier is. And again, I'll go through this a bit faster because a lot of this was covered in the prior panel, but this can be measured through considering quite a few factors, including uniqueness. Think through the possibility of duplication. For example, Mr. Gemechis in this prior to me spoke about the Ethiopian experience. For the HIV program in Ethiopia within the EMR, the ART program used the MRN identifier that is unique, but unique only in the context of that facility. But if the patient roams to a new facility or interacts with another system, a duplicate identifier typically is created. Now, to a certain extent, this may be addressed by the introduction of the National Civil Identifier, the Ethiopian FADA, as we heard from Mr. Gemechis. But there are other factors as well. Accuracy. Think of how error-prone your identity system is. For example, if manual data capture is required, there's potential for capturing your identifier using a wrong digit, and there's human error. Adoption is another key factor. If only a narrow portion of your population is registered, this will limit the efficacy of that. Availability and durability as well in terms of the expected lifetime of the ID used. So again, to lift out the need, investments need to focus on strong identifiers, but also linked to initiatives that are government-led to build alignment around these identity investments. Thinking about an identifier's population adoption being a primary indicator of its strength, you can also illustrate this with a few scenarios. So consider, for example, a biometric system implemented in one subnational region for one disease program only. Can this be used to link data across programs or other regions? Another scenario is a national civil ID issued to a percentage of the population over the age of 16, whereas a large percentage of the healthcare users are under 16. So these are examples of potentially strong ID systems that are being weakened by adoption levels. And to address this, we need initiatives that leverage drivers to boost patient registration on chosen ID systems. So example, Ethiopia encourages registration on the FADA system at banks prior to gaining access to banking services. In India, they leverage the mass vaccine drives to register large numbers and issue the national ID. The summary need is, again, for government-led initiatives to drive population adoption at national level. And the image to the right, this is a fun reference to the herd community concept that many may be familiar with. It's coming out of COVID, which you can think of as an analogy to the concept of an ID system reaching a point of effectiveness after broad-based population adoption. But still thinking about identifier strength and which identifier to get behind, let's attend to an important question. Can we just use one single identifier? And typically our view is that no identity system is perfect. No single solution can achieve a 100% match rate, for example. Instead, we should be considering a more hybrid solution that merges the strengths of varied identity systems. Also, being cognizant of multiple countries being in various states of maturity in the development of identification systems, and in the health sector, also development of their health information exchanges as well. So one scenario to imagine is leveraging a national civil ID issued at birth, which facilitates broad population reach and even multi-sectoral linkage. Then biometrics where applicable, so additional identification for verification against false identity, dealing with issues like fraud or stigma in the case of programs like HIV, and then applying multi-factor authentication as well. This is imperfect. You still have to cater for quite a few edge cases, including foreigners and refugees, nationals are not yet registered, or in emergency use cases where the issued ID is not available. But again, to lift up the need, investment and development to implement an integrated patient identity system to identify patients and additionally to verify that identification. So the ideal strong ID system will take time and investment to scale out and achieve high population adoption. How do we think about managing the transition to this end state? So let's go through some key illustrative questions. Now, what if patients needing care have not registered for a preferred ID system? Do you turn them away, or do you create a new patient file, also creating potential duplicates? In the case where 3 different ID systems are available at a facility, what logic do you use to match patients? Do you prefer one and ignore the others? When no stronger ID system exists, do you accept matching patients on weaker data fields, for example, demographic data, which itself also may lead to inaccuracy? And then assume the ideal identity system was fully implemented as of today. What about historical data? How do you link historical patient data that does not have the new identifier? So the need is to require a unified approach for varied patient identity systems to coexist and mature at scale at own pace. So as I mentioned earlier, and throughout this episode, an MPI was identified as a possible contributor to solutioning here. What is a master patient index? So fundamentally, it performs patient matching across health systems and stores the links between patient records in a centralized database for querying. So you can consider an MPI, a master patient index, or a client registry effectively building a model that represents the state of relatedness between every entity in the health ecosystem. And in the context, those entities are patients, as well as those patients, every one of those patients' interactions with the health system. So it's a fundamental building block within a country's health information exchange that creates a comprehensive longitudinal view of patient healthcare. Now let's clarify the distinction between an MPI, often other terms that are used, like a client registry, as well as a civil identity management system. So firstly, in most cases, the names MPI or client registry can be used interchangeably for the same component. The difference between an MPI and civil identity management system is that the latter is used to issue and manage a single ID system to a national population, whereas an MPI is a hub that integrates multiple ID systems and stores the linkages. So let's think about the capabilities that MPI can leverage to respond to the identity challenges in health that we have been outlining. A key concept here is identifier integration. You can consider using a graph database to store identifiers related to the same patient in a cluster. And unpacking this identifier cluster, every patient interaction with a health system has an associated source ID system. Example, an ID issued by an EMR. Again, typically these IDs are unique, but only unique to that source sending system, whether it's an EMR or a community-based system. Each patient interaction must then be matched to a patient cluster in the MPI. Typically, the MPI itself will be hosted centrally, but can also be follow a decentralized implementation, linked by an MPI-generated golden ID. And then the MPI can be queried with an identifier, and the cluster informs which other interactions are related to this patient. In some ways, health may be considered unique in this aspect of ID clusters. Example, the finance sector may have much fewer IDs per person. So think about how this capability can be leveraged to allow multiple varied ID systems to coexist in an integrated way. So let's take a look at another key capability, which we've come across quite a bit in some of the MPI patient identification management implementations that Gembi has been involved in recently. So this is fundamentally all about finding the balance between automation and facilitated manual verification of ID matches. First, it's really difficult to attain perfect matching using automation, regardless of how advanced your matching algorithms are and how attuned they are to the unique characteristics of the namespace that you're applying it to. And so we need human interaction to verify accuracy to a certain extent. However, depending on manual verification for every patient match is laborious, and sometimes, well, at least at national scale, it's not feasible. So there is a need to consider a hybrid approach to this. So typically, automatically matching on strongest identification systems available in a more deterministic way, then raising notifications where weaker identification systems contradict the stronger ones, and then finally channeling notifications to users who are best empowered to make decisions. For example, staff at health facilities who have the patient in front of them. And when thinking about MPI solutions, it's also important to consider not just the complexity of the data and the variability of the characteristics in the data set, the namespace and frequency distributions of key characteristics and missing data and transpositions and all those type of problems. But also, equally important is scale. So to get an idea, again, Mr. Gemechis spoke about just the incredible scale that Ethiopia's of the country of Ethiopia and the volume of transactions that an MPI and many of these other HIE components will need to manage. The population equates to the potential patients that you need to be able to cater for, the patients registered over time, so your existing patients multiplied by the volume of patient encounters you'd expect. And again, this is across the entire health system, not just for specific disease programs like HIV. So this becomes an extremely demanding and highly complex computational problem to solve when you're dealing with millions and millions of transactions. So every interaction becomes a process on the MPI, and we need to design the MPI to handle scale. For performance at scale solutions or considerations, I'll mention very quickly, based on our experience, has been firstly really being deliberate about the selection and evaluation of appropriate blocking techniques, methods, tools, and configurations. So this is effectively to help in reducing the search space for the high computation demand on an MPI. Considering stream processing and leveraging high performance messaging buses. So this will effectively help you with enabling not just synchronous communication with an MPI, regardless of how you apply it in a passive or active mode for transactional or batch processing, but also enabling asynchronous communication with your MPI service. And then also considering data stores that are optimized for querying identifier clusters like graph databases, etc. So in response to the need for highly scalable patient matching and linking solutions, amongst the few open source digital public goods that Gembi is contributing to in the open source community, we also built GemPI, which has been designed with a number of the capabilities that we've been talking about in this presentation. So GemPI is fully open source and free for the public to use and contribute. It's got a robust patient matching engine and graph store. And it's currently been implemented in a few countries, primarily here in Africa, with an active development team and supporting various types of scales of implementations. This is just I'll skim over this, but just a high-level view of the innards of the MPI engine itself that's been architected for high-performance scalability. I'd like to maybe just spend a few minutes before ending this presentation talking a bit about at least two countries and lifting them out, the experiences in terms of their road to implementing national scale MPI solutions. So the first is Sri Lanka, where we're piloting an MPI for a shared health record to drive a continuity of care use case for patients roaming from one health facility to another. So Sri Lanka recently has published their blueprint for the National Health Information Exchange. And then as they're moving through the process of implementing and rolling this out, they've defined what they call a thin slice of that architecture, where they're building the fundamental building blocks. And two components of that thin slice of their architecture is a shared health record, which is standards based on FHIR, and an MPI component. So that gives you a sense of how important an MPI is to actually get integrated and get that component working before you start building out more complex HRE type of workflows. For the SHR, the Open HIM global good platform is being used to rapidly deploy, or has been used to rapidly deploy, a pilot implementation of a shared health record based on the Open HRE architecture and the FHIR data exchange. And for the patient identification, that's been handled by the GemPI MPI engine to connect the 4 major EMRs in the country to integrate with the SHR and demonstrate data exchange. This is a more detailed view of what that exchange looks like. So on the left-hand side, you've got the sending source EMR systems that communicate via the interoperability layer to your clinical data store, which is FHIR-based. In this case, the implementation is using the Happy FHIR server. An important consideration or note to make here is the separation of the clinical data that's stored in the FHIR server and PII data, as had been again indicated in prior panels for data security purposes. And the vision for Sri Lanka is quite aggressive. So they're on the road to rolling this out, or actually building the infrastructure and then implementing it nationally. And their vision is to have, for this exchange, to process about 50 million patient encounters annually via a centralized shared health record to provide better continuum of care. I'll just very briefly make a quick plug for an event that's going to be held in Sri Lanka in November of 2024. That's the annual Open HRE conference. That will be quite a good opportunity for people in the community that's interested to learn more about how Sri Lanka is progressing in realizing that vision, as well as many other countries, not just in the AHIN network, but also here on the African continent. The second example, implementation of GemPI exists in Kenya through the National Data Warehouse. This is in collaboration with CDC and partners such as Palladium. So the Ministry of Health in Kenya implemented a national health ID, the NUPI, the National Unique Patient Identifier. I think about 50% of patient records are associated currently to a NUPI. And the MPI was required to consolidate all patients across multiple program databases, irrespective of whether they have a NUPI. So to give the NDW, the National Data Warehouse, a consolidated view of all patients across all disease programs. So the requirement was for deduplication of patient records not having NUPI. But interestingly, as we progressed through that project, which is still in flight, we had a requirement for the matching engine within the MPI to flag different patients that erroneously have the same NUPI as well. So that's been quite interesting. So this diagram just gives a different view of sending facilities that are submitting data directly into the National Data Warehouse. And here we've got a scenario where the MPI engine has been applied in a more passive mode. So asynchronously, it pulls data from the National Data Warehouse, it runs it through its deduplication engine and provides a report of possible duplicates of patients or patients that have visited multiple facilities, but are not necessarily linked to a single enterprise-wide client ID and are considered as separate, completely separate entities. But extremely interesting is that what the Kenyan team have done is they're making that information available directly to the health facility administrators who are registering and seeing patients directly. So this view here is of that report produced by the MPI, visible and available, integrated within the Kenyan EMR. So when the patient is in front of the administrator during registration or other key events, administrators are able to both make better decisions in terms of evaluating possible linkages of patients moving between multiple facilities, but also enrich that data and improve the overall data quality, which ultimately will improve the ability of any MPI engine to do patient matching and linking. So I think that's it for me. I'll end the presentation here, and just like again to thank the organizer, Dr. Atick, and others for giving us the opportunity to speak at this event. And I'll encourage the community to reach out to us if you have any challenges regarding patient identity and MPI-related implementation problems, and also to engage with us via the Open HRE community, as we are quite keen on building a global community of practice around this important problem. So
thank you, Wayne, for this fascinating presentation. We've actually ran out of time for this segment, but I have one quick question for you. Are you able to turn on your video? Because I knew you had turned it off because of bandwidth for the presentation. Good to see you. Just wanted to ask you, how would the MPI evolve if we were in a regime where we were able to federate different health systems with their own identifiers all federated? The concept of federation would be the patient would use whatever health entry point that they want to, whatever one they have the most trust in, and that federation becomes essentially their identifier that vouches for them. Think about the system in the US, for example, driver's license in a state becomes essentially through the federation, becomes your identifier. I don't need an ID in California, I have an ID in New York. So how do you see of course, legacy will still be legacy, but going forward, if we federate health identifiers, how do we improve the efficiency of the MPI or in the patient identification process?
Thanks. I think it's a really good question. I think that part of the design of an MPI is to be able to cater for that. So I think implicitly it should be able to expand to a federated implementation. So being able to host multiple identifiers, depending on what's actually available, and then over time, build out the appropriate model of linking based on the strength and the characteristics of the identifiers, as well as backing demographic information, for example, that's available to make possible linkages. I think an important point is that as much as there's a lot of advancement being made in complex algorithms and the introduction of AI and appropriate machine learning algorithms to help with that matching process, the need for appropriate human verification processes to be incorporated in whatever use cases are being implemented.
So what is really sorely missing is actually standard for federating IDs, so that if an international organization, maybe the WHO, can take that lead on and say basically any country, any agency, etc. If you adopt the standards in this way, then platforms like Master Patient Index could even harmonize with legacy systems, because you're trying to simulate actually what a federation hub would do.
Yep, that's exactly right.
Excellent. So very interesting, and we're going to continue to hear about your progress and others. I thank you to Ethiopia as well for this segment. Both are fascinating keynotes. So appreciate it. Now we're going to move on to the fourth segment. Again, some more interesting things. The key one is going to be from, the first one is going to be from Chris Fleming, which will focus on how a country that doesn't have a national identity system or a foundational identity system is able to create a very efficient and effective health identification platform. So Chris, thank you for being with us. The stage is yours.
Thank you very much. Can you hear me okay?
Yes, we can.
That's great. And you can see my slides okay. I'll assume that you will shout if you can't. Hello, everyone. And thank you very much for coming to this event today. I've really, really enjoyed listening to all the presentations. And I want to talk to you over the next sort of 10 minutes or so about the role of ID in the development of digital services in the UK's National Health Service. So my name is Chris Fleming. I'm a partner in a organization called Public Digital. I'm a digital transformation specialist, specifically focused on healthcare. I have a product management background. And within Public Digital, I lead our health and care practice. So I'm across our various digital health projects. My background is I spent many years delivering national scale products and services and platforms for the UK's National Health Service, which I will talk about more in a moment. Very briefly, Public Digital is a specialist digital transformation consultancy, and we work with organizations of all types to create the conditions to achieve change at scale. We are based in London and do a lot of work domestically in the UK, but also work internationally in Latin America and Africa, both directly with government administrations, but also via multilaterals like the World Bank or the Gates Foundation. And that work has ranged from helping to set up new digital units, for instance, in Madagascar, to building digital teams and capability in Nigeria and so on. You can see some examples on the slide. And we're currently setting up our first overseas office, which will be in Abuja, Nigeria, which is very, very exciting for us. I'm going to start my presentation at the end, which is where we are today. So I'm going to describe that and then give some reflections on kind of the steps that were required to get here. I'm going to talk a lot about the NHS today, the National Health Service. So firstly, for those not familiar with the NHS, it's the organisation that runs our health provision in the UK. It provides care nationally, free at the point of use, which we pay through taxation. The NHS is actually the world's 7th biggest employer. It has 1.7 million staff and deals with around just over 500 million patient contacts per year. And every user of the National Health Service can access something called the NHS app. You can download it from app stores, and it allows everyone who has it and has been through the registration process to interact with NHS services. So you can access your medical record, you can book doctor's appointments, you can order prescriptions, you can participate in medical research or get emergency help and so on. And I was product director for the NHS app for a couple of years between 2019 and 2020. And you can see on the slide here a screen grab of my own NHS app homepage, but I'm one of 32 million registered NHS app users. And what I really want to talk about today is not the NHS app per se, but a very, very important platform that enables it, which is called NHS Login. So NHS Login is an ID and authentication platform that provides patients with a simple, secure, and reusable way to access the NHS app. But as it's a platform service, not only does it enable access to the NHS app, it also provides that kind of sign-on, single sign-on to multiple other digital health and care services and apps. You know, the NHS app, as I say, it's a nationally provisioned, but it will never be able to do everything. You know, there are so many different specialist products that serve particular conditions, everything from diabetes to COPD, different hospital EMR solutions and different patient portals. So as well as the NHS app, NHS Login provides that authentication route into over 70 other integrated digital products and services, which are provided by, you know, the private sector as well, not just the state or NHS products. And when I grabbed this data, it was probably a few months ago now, it had enabled 1.3 billion logins overall. And I want to give a shout out to my erstwhile colleague, Melissa Rusco, who leads this program still and has done a brilliant job. So that's where we are today. And, you know, hopefully you'll agree we've probably ended up in quite a strong position. I mean, the digital estate in the NHS is by no means perfect. It is a real mess. Like all of the places you're dealing with, it's extremely, you know, complex for all the reasons that have been talked about over the course of the afternoon. But all that aside, you know, we're in quite a good place in terms of our sort of nationally provisioned patient-facing services. So how do we get there? I wanted to share some reflections on what I think are the kind of, if you like, the conditions that helped us achieve that goal. And firstly, I wanted to talk about political will and mandate. You know, it's really important to have a very, very solid and clear strategy. In our experience in public digital, working across many sectors and many different countries and administrations, a clear strategy, a political will and mandate is a prerequisite to any major digital transformation and change. There has to be that buy-in from the top of the shop, if you like, that mandate. And the strategy has to be consistent. Where I see digital strategies fail are when people zigzag and off their course and kind of lose sight of the outcomes they're aiming from. A lot of these systems, because of the complexity of health ecosystems, they can take a long time to mature and a long time to realize benefits. So you kind of have to have that long-term strategy to stick to. In this case, the most senior health minister was very much behind the plan, and you can see him announcing it there in Digital Health and Industry magazine at the time. He was very, very clear on his strategy. The second thing I wanted to talk about is one of the conditions that drove the success of these kind of platforms was the necessity born out of a crisis. And Wayne talked about adoption, in his presentation. This is so important. I'm sure you have all heard the phrase, never waste a good crisis, and that is so true. But what I mean is that a crisis or a kind of a burning platform for change can often give you a window of opportunity to do something radical. So NHS Login and NHS App were conceived of and built before the COVID pandemic. But the user base at that time was they were in the low millions. And there was quite a lot of, I suppose, there was a recognition that much more investment was going to be required on adoption. But then the pandemic struck and the government introduced vaccination records, the COVID pass. And because of the existence of Login as the ID platform and the app, we were able to instantly integrate records and code. And that, because of the necessity of having the COVID pass, drove adoption through the roof and meant that it's got extremely high penetration through the population. And the picture there is a photograph I took. I don't know if there are any soccer fans on the call, but that's outside Wembley Stadium during England versus Croatia in the 2020 European Championships final, which actually played in 21. But there you can see we had to have teams of people helping people with the NHS app who are getting stuck, sort of accessing their COVID pass to get into the stadium. The third element I want to talk about is that there were critical infrastructure components that were in place already. There's, Login and app didn't come in and have on a standing start and were able to achieve all these things. There are a lot of foundational elements that were in place already. So the UK does not have a unique foundational national ID approach. Such an approach was attempted back in 2016 under the Labour government, or 2006 rather, but was thrown out. It wasn't possible to achieve. It didn't have the political sort of headroom to get through. So instead, we have a specific functional ID, like your passport, a national insurance number, or a driver's license, and there is a specific ID, functional ID in health. So NHS user has a what's called your NHS number, and you get that the first time you register with a doctor in the UK. You can do that online. You can register to get an NHS number online, but you don't have to. You can also do it by paper, in person at a doctor's surgery, and get sent a physical card if you are not online. To get so that's the unique NHS identifier. To get an NHS login, which enables this access to the digital services, you need an email address and a phone number, and your demographics are then connected to your existing NHS identifier. There's then a separate ID verification step if you want to access the most sensitive data that's held. So your medical record, as we've talked about multiple times, this afternoon, it's very, very sensitive data. It's special category data. So to verify, you need to upload a photograph of your passport and then record a video of yourself confirming your identity. And that all gets triangulated by a third-party ID verification service. So all of that was in place. The other thing that I think is really, really important to mention is that 100% of GP, of primary care physician practices in the UK are digitized. They work on EMR systems. And the GP is where your main record is kept. So even if you go to hospital, all that information in your hospital is by default sent back to your primary care physician's medical record. So there is a canonical medical health record that sits in the GP system, and so NHS login in the app provided the means of the patient accessing that data, which was already in use by clinicians, in the country. Alongside the technical infrastructure, there is some necessary governance infrastructure. So we've talked about the development of legislation in different countries. So there is a fairly well-developed legislative regime that talks about the treatment of patient data. And actually, the sharing of data for what we call direct care, so for people actually getting treatment, is quite permissive. It's quite permissive legislation. It basically says, if someone is worried about the care of a patient, you can share that medical data about them. It's much stricter when it comes to secondary uses. So using that data for purposes other than direct care, which might be research or other things like that, where it's very important to get consent. Fourthly, and this is a really important point for anything that you are building or creating, and all of the, I know I could tell there was some sort of experienced product people on the call in some of the talks that we heard earlier. It's really important to take a person-centered design approach to what you're doing. And what that means in practice is ensuring that you have design and designers working on your systems and having design embedded to ensure that so in the case of NHS Login, that ensured that the onboarding process for patients was really, really quick, was really slick, provided a great experience, worked on any device, was accessible for people who had different needs because of disabilities, whether that's with their sight or motor skills. But in addition to designing that experience well for patients, also, the team made onboarding for suppliers really, really quick and easy and well designed. So there was access to very, very clear documentation, software development kit, test environments that were easy to get into, and so on, and really streamlined that governance process as well. And so by making the onboarding of suppliers a really slick experience, that helped the scaling and helped them integrate into more products. And as I say, just to reiterate, you don't have to have NHS login and you don't have to have digital access to get to access NHS services. And that's really important because actually it's sometimes those people who aren't online who have the most in need of healthcare. But this is about providing a convenient route for those who can to find efficiencies and increase resources for those who can't. And I'm going to make one final point before finishing, which is at the heart of all of this is having a sustained multidisciplinary team. And just to unpack that, multidisciplinary, the team has all the skills needed to develop the product and service, which is developers, researchers, designers, but also the skills needed to manage the safety, the governance, the security. So the whole team pulling together towards the same outcome. Second is agile. So by that, I mean taking an iterative approach, not designing everything up front, but creating a minimum viable product and service and testing that with users, creating fast feedback loops to quickly learn and scale. So for something like this, the launch of the service is the start of the journey, not the end. And finally, sustained. This isn't a project that is one and done. You need a team in place for many years that can build that institutional knowledge and the knowledge of user needs and is able to respond to those over time. So sustained teams with predictable funding. And if I could sum up my whole presentation in one slide, the secret to success is this: build, empower, and sustain brilliant teams. And I will leave it there.
Chris, well done. Brilliant presentation and brilliant ending. We ran out of time, but I have to ask you this question because I think many might be wondering the same. You mentioned that the GP, which is the general practitioner, for some of us who don't use a British terminology, the GP is where all the records are kept. So we're talking about a distributed health record data management system in the UK, or is it just a heterogeneous, it's just whatever the PC at the GP's office is? What are we talking about?
Great question. So, it's a very messy situation in the NHS. As I said, we're absolutely not perfect. There are 6,000 GP practices, and that's the first port of call for everyone who goes to interact with the healthcare service. If you need to get to a hospital, your GP has to refer you. So GP is the first port of call. Of those 6,000, the software that they use in those practices is one of two suppliers. We have a duopoly situation in the UK. They're called EMIS and TPP. They're both British-based companies, and they provide that software. Now, that duopoly both gives some advantages in terms of the ease of interoperability, but it actually gives some disadvantages in terms of the market and competition and innovation. So there are pros and cons.
Right. So while I like the idea of decentralizing data so that I don't create honeypots, can I trust a local GP to really protect the data? Because I understand this data must be accessible from my app. So I have to be able to access that data. How are they ensuring the audit and the standards of information security at each one of these 6,000 locations?
Yeah, it's a great shout. So on the technical side, there's an organization called NHS Digital, which has multiple teams of people who assess the clinical safety and the cybersecurity of any clinical system that's being used in the NHS. So they would work directly with the vendors themselves to check their cloud infrastructure, to check their pipelines, to check their security policies and practices. In terms of the actual human factors of security, like how you drive good behaviors in those practices, that's a mixture of legislation that prevents that makes it illegal to do certain things with data. And then there's also an education and skills piece in which doctors and practice managers are required to undergo specific trainings to help them understand and undertake the proper treatment of data. So it's a combination of factors that provide that kind of assurance and security.
Okay, I mean, it's wonderful to hear that. I think despite the messiness, because this is, as I started this whole episode, I made it clear, this is not a simple topic. There's going to be messiness everywhere. It's going to take us a couple of years to just deliberate and try to understand our way around it. I think the UK does provide a model that merits to be examined by other countries around the world, because you're addressing issues such as privacy by design, you're addressing accessibility, you're addressing the fact that you really don't need a foundational ID to create an effective health ID. So congratulations for having thought through the issues in that way. The implementation is a different level, it's in different hands, but we appreciate you taking the time to share with us these insights, and we look forward to learning more for our community as we go forward. So thank you, Chris, once again.
Pleasure. I'll be very, very happy to share more and also share information on all the mistakes we've made over the years as
Wonderful.
well.
I'm sure we're going to engage with you again. Thank you.
All right. Thank you.
We will continue. As you can see, we've got a whole wealth of information throughout this episode, wonderful insights on a complex topic. We are going to now talk about last mile. What happens when you're trying to deliver health services in last mile? How do you ensure that the right health service is reaching the right person? And with that, the role of biometrics becomes very, very important. And one of the companies, and actually not-for-profit organization that we like to work with and like to see on our platforms is Simprint, who is going to be sharing with us their experiences in some real-world scenarios. I guess, Edge, welcome to the LiveCast, and I'd like you to take the stage.
Thank you very much. Thank you, everybody, for giving us an opportunity to talk to you today. As Dr. Atick said, my name is Edge Asangbedo. I'm the Director of Partnerships at Simprint. We're a not-for-profit organization. We build technology to radically improve transparency and effectiveness in global health delivery services. Today, I'm just going to talk to you about biometrics and how we can use this to unlock access to healthcare. A lack of ID, as we've heard through the course of these presentations today, can be a barrier to healthcare access. Healthcare is a universal human right, which everyone should have access to. However, there are a number of communities worldwide that are missing out on continuity of healthcare and life-saving services that are meant for them because they have no safe, reliable mobile form of ID. I just want to just give you a run of what the current situation can look like, and using our protagonist, Maria. So if we look at Maria, Maria arrives at a clinic with symptoms of schistosomiasis, which is an infection caused by parasitic worms. She starts her treatment and she gets a record created for her. A month later, Maria visits a different village and seeks treatment for continued symptoms at different facilities. A new record is created in her hometown. Maria now has two records that are not talking to each other. After her marriage, Maria visits a clinic as she's still feeling unwell from the schistosomiasis infection, but presents herself as in her new married name, and a third record is created. We now have a situation where we have one person, 3 records, not communicating with each other. There are a number of consequences for this. For the program participants, so for Maria, the possibility of incorrect treatment administration. There might be some insensitivity in continuity of care for stigmatized conditions, which could lead to worsening conditions after loss to follow-up. For program managers, the lack of reliable data for monitoring and reporting means that there could be ghost clients and duplicates. There could be ineffective policy interventions based on reliable data, and then the frontline worker is not accountable. When we can fix the person's identity to them, we enable one identity per patient across all their healthcare needs. There's been a number of talks today about the foundational versus functional ID. National ID systems do exist, which are functional, which could be foundational ID. But health ID is a functional ID.
Ed, one moment. We're not seeing your slides.
Oh.
Yes. Somehow
oh, no.
So
hang on 1 second. Sorry.
Okay.
Thank you for flagging that. I didn't. Let me try again.
Okay,
I'm sharing screen. It's telling me I'm sharing screen, but let me try again. 1 second.
There you go. Yes.
Are you seeing me now?
Excellent. Yes, now we're connected. Good.
Okay. Thank you. Thank you so much. And I will share the slides at the end for anybody who missed the top of it. And so identity fixing can be achieved through a functional identity and not necessarily as a legal identity. So biometrics can be a solution to the problem. Using biometrics to using biometrics to create a fixed identity for an individual, which moves with them over time across systems and locations, will help unlock access to healthcare. So if we go back to the scenario I gave earlier on about Maria, who was receiving care, who received 3 different sets of care in 3 different clinics and were not linked. If we use her biometric identity, those would all be linked and they would just travel with her wherever she went to receive treatment. A biometric, just talking about what the principles of biometric identity is, it should be fit for purpose and, beneficiary applicable. It should be interoperable, which means they just integrate into existing systems that are already in place. And at the very, very heart of this, privacy and data security first. So biometric technology can resolve the challenges of delivering health services at the last mile. And if you look at this, this graphic I'm showing here, it can be really, really easy for the health worker to collect the data using a device, a smartphone or a tablet. They can seamlessly create it. They can seamlessly collect the data using face, fingerprint, or palm image. And it runs an algorithm and a unique identity is created, which is transportable with the individual and interoperable into different existing data collection platforms like DHIS2 and like ComCare, etc. The data is stored in an interoperable template, is integrated into various platforms, and we have this idea of one client, one record. And if you look at the graphic I'm showing on the screen now, it's showing all different areas in which a patient's records can be linked into one single source for the patient. So I want to talk to you about biometric impact in the last health. So this is more specifically what Simprints have seen in organizations and in projects that we have worked in across different settings. So in the Bukwe region in Uganda, we're expecting to see an 18% increase in people receiving a complete course of the COVID-19 vaccine. In Malawi, a HIV use case shows that there are 29% more visits when using biometrics versus electronic medical record system. Maternal health care in slums, Bangladesh, 11% more postnatal care visits. In Ethiopia, we have been working with the Ministry of Health in Ethiopia, and Gemechis spoke earlier on about a couple of the programs that we have been involved in around trachoma tracking and the ECHIS system. The Ethiopian Ministry of Health chose to deploy biometrics to ensure medicines reach vulnerable communities. Over 870 patients have been, 70,000 patients have been enrolled and healthcare delivery verified with biometrics. The Ministry of Health wants to scale to reach a further 25 million people. In Ghana, working with our partners at the Ghana Health Services and Gavi, we have completed a phase 1 project with proof of impact in the Eastern region. This has been integrated into DHIS2 e-tracker. Biometric data is not linked to other national ID and is a strong community acceptance. We will now be rolling out in phase 2, which is starting this year for another 3 years. We'll be rolling out to more clinics and we'll be integrating child and adult biometrics in this program. The hope is we will be including this in the malaria vaccine in this and ensuring that course completion is secured. One of the problems with the malaria vaccine is that there are 4 doses that need to be administered in full to be fully effective, and we're seeing that there has been a dropout between doses 3 and 4, and we're hoping that our system and working with the Ghana Health Services, we will be able to eliminate that dropout rate. In biometrics, Simprints has been able to biometrically identify children as young as 9 months ahead of vaccination in Bangladesh, which has created reliable and verifiable records. Across 50 clinics, we have verified over 7,000 children receiving their first measles vaccine and over 4,000 for the second dose of the vaccine. And I really like this user feedback from Malawi in a project that we worked on, the HIV project that we worked on, and the research coordinator saying that the digital innovation really helped us. At the touch of the scanner, we could get the participant's ID easily. Confidentiality is maintained, privacy is maintained. So I think this has been a wonderful collaboration. Just want to finish by saying biometrics is a solution. Digital ID powered by biometrics can ensure unique client records across medical clinics, across health interventions, and across partner digital systems. Thank you very much for your time. Apologies for you not seeing the start of the slides, but I'm really happy to share if anyone would like them. Thank you very much.
No problem, Edge. Let me ask you, Simprint has been doing a lot of wonderful last mile programs in a lot of countries around the world, which means you're responding to a clearly a demand that is happening as we speak. But the issue is, how do we avoid creating silos? I mean, you're doing the program specific. Yes, that helps in that we're doing the data relates to the program, doesn't go anywhere, and therefore there is less concern about leakage and privacy and issues like that. But ultimately, when you scale up, this is an investment. How can a country take a Simprint program, which was intended for one aspect, let's say malaria vaccination, and try to leverage that data for something else?
Yeah, it's a really good point. And we tend to, whenever we go into any setting, we're always looking at what the scale up look like and how can we exit responsibly at a suitable time. And one of the ways that this is that our technology is going open source. So we have now put our first open source codes up on GitHub, and we're hoping that in the next 2 or 3 years we will be fully open source and have a fully open source technology. So the idea is that in any setting, in anything that we're using, we work very. I just want to go back to the example of Ghana, for instance, because that's what on the slide. We work very, very closely with the Ghana Health Services, and we really make sure we understand what their needs are, not just for that project, but for other projects. And we want to look across different verticals. So in order to avoid those silos, we make sure that we do the level of training with the users and make sure that people are comfortable with the technology. The technology going open source is another way that we're going to ensure that when we leave or when the funding stops, they're able to carry on with the technology.
And I would return to one point I raised with Wayne, which is the idea that, let's say, a health program like malaria vaccination is imprint-driven. If we can achieve federation between programs, so in fact, somebody that gotten enrolled because at some point there was a touch point that they had to go through within the health system, but that enrolled once in one program, you federate, and therefore that person could be able to use that identifier into a next program. And so the issue here is for us to move towards a standard that allows one health program to share identifiers or identification data to another program. And I would imagine you being open source, you could be also, it's possible for you to move into a standards-based identification model.
Yeah, I think ultimately, Dr. Atick, that would be, that is the
roadmap,
the North Star. That's where we want to be. That's what we would love to see. I would love to see that. I would love to see a system whereby, somebody who's receiving treatment from TB, those records are then linked to the malaria treatment or the HPV vaccine. All those are linked. We're not there yet, but it's certainly the right direction. We're moving in the right direction. And, one day we will get there.
Okay, let's just federate the health identifier ecosystem. Thank you so much, Ed. We really enjoyed your presentation. We look forward to hearing more from you in the future. Okay,
thank you very much.
Finally, last but not least, the presentation that you've all been waiting for. And this has to do with leveraging health as a driver of legal identity. Basically, not just as a demand driver, because it's a good use case of digital identity or legal identity, but also health has a lot of touch points with the population. And are there ways in which we can leverage those touch points to bring in more health, more civil registration related registrations, such as birth and death and other vital events? And so we're going to bring back Bhaskar, and we're going to add Beatrice Plaza from Vital Strategies, who are going to share with us some research-backed presentation based on data from countries that they've been moving into about the effectiveness of this twinning approach. So I'll leave this in your hands, Beatrice and Bhaskar. Thank you for being with us once again.
Sorry, Beatrice, you're on mute. Could you unmute, please?
Sorry, thank you. Long day. Thank you, Dr. Atick, for this opportunity to raise this issue in this very, very interesting discussion throughout the morning. And also thank you to the audience for having held on until the end for this presentation, because it's been very, very interesting, lots of learning. Our presentation is, as Dr. Atick said, is focused on boosting civil registration via health infrastructure mobilization. So a civil registration and vital statistics system that registers all vital events from birth until death for the whole population provides the foundation for an effective identity system. Despite the importance of strong CRVS systems, 237 million children under 5 lack proof of identity, 167 million are not registered, and 70 million go uncertified. For baby in sub-Saharan Africa, 119 million, or 67% of children under 5 lack proof of identity. For babies under 59 million lack proof of identity, 42 million are not registered, and 17 million go uncertified. In sub-Saharan Africa alone, 27 million, or 71% of under 1s lack proof of identity, and 22 million are not registered, and 5 million go uncertified. A significant proportion of these births are registered after the legally prescribed period and beyond 1 year. So why does this happen? Missed opportunities. Not all institutional births are notified, declared, registered, and certified. A substantial chunk of home births are not even reported, and most deaths are not reported as they happen at home. So maternal health services and immunization programs represent opportunities for facilitating the registration of live births. However, there is good evidence from several regions in Africa to suggest that such opportunities are regularly being missed. For example, in Eastern Africa, 47% of women gave birth in a health facility, and 86% of newborns received the BCG vaccine, which is routinely administered at birth by the birth attendant, but only 33% of births under 1 are registered. In Southern Africa, 73% of deliveries occur in a health facility, and 78% of babies receive the BCG vaccine, yet only 46% of births are registered in under 1. The discrepancy between institutional deliveries, BCG immunization, and birth registration rates is indicative of the significant potential for increasing birth registration rates by capitalizing on health sector contact at the time of delivery. In response to the weak civil registration systems that have left and leave many births and deaths unregistered and uncounted, in 2021, a guidance document was developed by UNICEF and WHO. It was the first time that we have a proper document on the issue. The guidance presents best practice scenarios of the role of the health sector in birth, stillbirth, and death notification, registration, and certification. We then realized the need to create use cases focusing on declaration, registration, and certification, so WHO, UNICEF, and Vital Strategies and other partners came together to develop an addendum to this guidance note titled The Health Sector in Civil Registration, Options and Methods to Increase Registration of Live Births, Stillbirths, and Deaths. The guidance presents options for the role of the health sector in CRVS and methods for co-locating civil registrars within health facilities, and is meant to be used with the WHO UNICEF guidance help that I first presented here. And last year, we developed a 3-module e-learning course on leveraging the health sector to strengthen the civil registration of births and deaths. And this was developed also with UNICEF, WHO, and Vital Strategies. And the e-learning module has been converted into an Agora platform, and the course is available in both English and French. Four countries are following different modalities of engagement, and they are at different stages of integration. For example, Rwanda has an end-to-end digitized and integrated system whereby registration of newborns is done by the health staff. Tanzania has a simplified birth registration system where registration as well as certification for children under 5 is done at health facilities. Cameroon is co-locating civil registration offices in health facilities by expanding civil registration bureaus in health facilities and having healthcare workers ensure that birth and death notifications and forms are transferred directly to the civil registrar for legal registration. Benin is exclusively registering newborns by the health staff. So by mobilizing the health sector and integrating civil registration activities into healthcare services, countries can improve the completeness, the accuracy, the timeliness of vital statistics, which are all essential for effective public health planning and policy making, and thereby also strengthen ID systems. Lastly, these 8 countries have made significant improvements in under 5 birth registration, contributing to health sector integration with the civil registration. By leveraging birth registration data, health authorities can better understand the health needs, target interventions effectively, and ultimately improve child health outcomes. For example, Malawi has made significant improvement in birth registration of under 5s, from a previous 6% to 67%. Rwanda, as mentioned, has also made significant improvements in birth registration of under 5s, from a previous 56% to 86%. And Tanzania has gone from a mere 26% to 68% in under 5 registration. So my colleague Bhaskar will now present more detailed aspects. On to you. Over to you, Bhaskar.
So thank you, Beatrice, for setting the context, highlighting country examples, and showing the results. I will focus on the how part of it. That is how health facilities can play a role across the continuum of services. As you can see, it ranges from pre-birth opportunities for demand creation to post-registration data sharing. In between comes notification, which amounts to sending an alert about the occurrence of an event, declaration where health staff act as informants or facilitate declaration, validation where information sent or furnished by the health sector is validated and endorsed by parents as well as registrars. And then finally, registration and certifications. Health facilities provide on-site registration and certification services, either by deploying civil registrars or through delegation of responsibilities. Can we go to the next slide, please? Besides creating awareness of why and how of birth and death registration, pre-birth interactions can also be used to educate mothers or parents on the types of documents required for registration and inform them about the mandatory requirements of NID cards or numbers so that they have sufficient time to get registration done. Since the delay in naming a baby at birth is a big cultural issue across several countries, health staff can educate mothers to be ready with their baby's name so that registration is completed immediately after birth. They can also inform mothers about the importance of timely registration, as they are mostly done without any fees, and the first copy of birth certificate and even the death certificate is also provided free of charge. At the same time, health staff can alert parents about the implications of late and delayed registration regarding witness requirements, additional documentations, and fines. And in several cases, especially in Francophone countries, they have to go to court to get an order for registration. Parents will have to visit civil registration offices in the case of late and delayed registration, which will entail extra time and indirect costs. Coming to notification, it's time to move away from it. Mother and child health cards, delivery cards, or vaccination cards can be used as proof of birth, which is happening in more and more countries. The routine health sector data can be used to send alerts to civil registration system, and this can happen between two systems without any manual intervention. Health records as proof of birth can improve the reporting of home births and can be used for follow-up with parents for declaration, as mother and child health cards have a place to record birth registration numbers. Can we go to the next slide, please? So as informants, health staff can fill out the declaration form, sign them, and send them to civil registries. Or they can help parents fill in the declaration forms, get their signatures or thumb impressions, and send the completed forms to civil registries. In either case, parents need not travel to civil registries. Community health workers can perform the same role for home births and deaths. When it comes to registration, there are 3 practices that Beatrice also mentioned. Registration can be done at health facilities, but certification will require a visit to the civil registry. Registration and certification can be done on-site, either by deputing a civil registrar or delegating the responsibility of registration and certification to health staff. These practices help address the core issues of accessibility, that is distance, and affordability, that is cost, and play a crucial role in improving the uptake of timely registration. Can we go to the next slide? Twinning with the health sector has been a time-tested and game-changing strategies, and UNICEF with partners have been working in this area for more than a decade now. To assess the extent of integration between the 2 sectors, we introduced an outcome indicator in 2021. The indicator captures 6 mutually exclusive and exhaustive scenarios: no engagement, only notification, only declaration, registration but certification at civil registries, on-site registration and certification by deploying a civil registrar, and registration and certification under full delegation to health staff. Now we have data for 3 years, and I can tell you Africa is doing pretty well compared to other continents. For 2023, we have data from 45 countries covering 136,000 health facilities. As you can see in the pie chart, 72% of these facilities provide at least declaration services. The proportion of health facilities with no engagement and only notification is gradually declining. There are 19 countries where 80% or more health facilities provide declaration or registration and certification services. So that way we are on the right track. Next slide, please. So what will make it work? This is the most important slide, and I have picked 6 critical areas. There are several more. First, there is an urgent need for harmonized data standards among the health, civil registration, and national ID sectors to promote the use of routine health sector data for notification, declaration, and registration. This is the biggest bottleneck that most countries face and requires immediate attention. Second, the health sector should put more effort into improving the coverage of case level data, individual level data, by decentralizing DHIS2 and netting community events. Aggregated information, as you know, masks data quality, rather sometimes it misleads. The quality of health sector data is another concern. Countries that want to use or use routine health sector data face an uphill task. Third, civil registration authorities should take proactive steps to move from notification to declaration and registration. Removing notifications will balance the workload of health staff, and it cuts one step to bring the system closer to the one-stop approach. Fourth, civil registration authorities should use health records as proof of birth and that to facilitate this. Fifth, use MOUs to start this collaboration pending amendments to civil registration laws. Several countries have effectively used this as an interim measure. This is also an API CRBS recommended good practice. Sixth and last, we must know what health facilities can do and what they can't. This is extremely important to set expectations on both sides. Health facilities will do declaration, registration, and certification and send the records to the nearest civil registration offices. Beyond working as the first contact point, they cannot undertake other activities of a civil registrar, such as corrections, amendments, extra copies of certificates, etc. So if we have clarity on this, I think the engagement and collaboration would become much smoother. Next slide, please. So why is the health civil registration national ID pathway critical? It's important on several counts. Unique identification numbers can be issued at birth registration, establishing an organic relationship with the national ID system. Health facilities can capture the national ID of parents during antenatal services. This will provide 4 to 5 months to parents without national ID registration and national ID authorities to follow up, rather than denying birth registration of their babies for a lack of national ID card or number. Given the critical role national ID system have started playing in providing essential services such as health insurance, maternity benefits, and various types of pensions, countries must take immediate measures to improve the uptake of death registration. And community health workers can play a very important role in this regard. And finally, such a pathway will entail two advantages: collecting information once and using it multiple times, and moving information, not people. On the right side, you see a depiction of a steady state of a population register or the national ID system. This water tank analogy reiterates the importance of birth and death registration and reminds us of the role the health sector and CR sectors can play. Can we go to the next slide? So this is the last slide. Like as Joseph said, we will continue discussing the topic, and please join us on day 4 at the ID for Africa AGM, Forum 1, where we are going to discuss how an integrated health, civil registration, and national ID system is the way forward. Thank you.
Thank you. Thank you, Bhaskar, and thank you, Beatrice, for this really, really encouraging set of data and results. I just have a very quick question for you. You showed amazing progress. You talk about Malawi going tenfold improvement. What was the investment needed? Was it just change in the business process and adopting something better? Or was there a need to invest along the way? Could you explain the mechanics of this?
So in Malawi, the system was, like centralized. So for everything, like parents had to visit to district headquarters. Okay. So what they did, they took a couple of measures. They simplified the business process. First, they started with notification at health facilities. When they realized that things were not improving, then, like they gave additional responsibility to health facilities. Now registration takes place at health facilities. And that's how you see a big jump. But still, like if you compare the gap between registration and certification, there are some concerns, like 67% is the birth registration rate, but certification rate is just less than 20%. Okay, so there are areas, but what the idea was to tell you that, hey, if you capitalize on the opportunities coming from the health sector, you can have significant improvement in a much shorter span of time, like 6 to 7 years, because all these countries improved in 5 to 6 or maximum 7 years.
Okay, let me ask Beatrice another question. Beatrice, the health workers often tell us, and maybe they tell you as well, that their mission is not to be registrars. The mission is to basically deliver the critical health services that they're required. They're understaffed and typically have to handle a workload. And the last thing they want to do is to get another task. What motivates them to participate in this twinning program?
Thank you, Dr. Atick. I think one of the most important thing is a lot of these countries have also gone through these business process mapping exercises where we involve a lot of healthcare professionals at times in different countries. And so they see the need for this, right? They're able to realize where these gaps are and where the bottlenecks are and how things can be so much more efficient if they know that the family is not given the sole responsibility of then, after having had a birth, to go register the child. Most of these countries that we've seen an increase also is the co-location, what I referred to, co-locating civil registrar bureaus within the health facilities, which is helping because then you have the health worker can go right straight to a bureau that's within the facility. So I think that's making, we're shifting from a very passive system to an active system where we're taking the responsibility away from the mother, from the family, and putting it on the health sector to be more involved.
I have to say, this is one of the most promising developments in the fight to ensure everybody is registered and as close to birth as possible. I think we've ran out of time long ago, but we look forward to continuing this at the AGM, as you said, Bhaskar, and hopefully we'll see many of you there. So thank you once again for being with us, and thank you to the audience for having stayed. It's a remarkable that you have gone in for more than 3 hours and 15 minutes. But that means this is a topic that deserves our attention. So thanks for everybody once again. And don't forget, if you're coming to AGM, register quickly, because we may be closing certain segments. The demand has been very high. So thank you.
Thank you, Joseph. Thank you.